Welcome to everybody to our third day of the e-health conference here in Tallinn. We're running today half-day session that will be topped by a very awaited speech from our president, Kersti Kaljulaid, that will start at 12:30. So I hope everybody who has made to Creative Harbor for Estonian autumn rain is staying for that, and we are closing this conference nicely all together, since it's been really interesting 3-day discussion, and that will continue. Yesterday, when we were sitting here in the midday, the weather showed us how connected Europe is, because it's interesting, the Portuguese forest fires and the ash and smoke from there, the Egyptian Saharan sand and winds from the Atlantic Ocean all made to Estonia here on the European Union's east side and made our day yesterday really dark. So that shows how small Europe actually is and how connected we are. But we start today, as usual, with some safety instructions.
Welcome to the conference. Before kicking things off, we would like to take a few moments to go over some important safety instructions. To ensure your safety and well-being, the conference area is secured by the Estonian police. In the case of an emergency situation, we kindly ask you to follow their safety instructions. In the case of an emergency, we will sound an alarm. The alarm will ring continuously for over a minute, or will be activated twice within 5 minutes. After the alarm, we will initiate the evacuation of the building, and you will be required to proceed to your nearest exit. Please take note of the green lit emergency exit signs around you. There are 4 marked exits in the black box. 2 are located along the back wall, and a further 2 on the left and right. There are 13 emergency exits out of the building, 11 of which are located on the first floor. Once you have exited the building, head directly to the designated assembly point, which is located behind the building, on the pedestrian walkway near the parking lot. In the case of an emergency, we would ask that you remain at the assembly point until every person has been accounted for and you have been cleared to leave by the rescue workers. And with these simple and easy steps, we conclude our safety announcement. Thank you for your attention, and we wish you a safe and pleasant conference.
So I'm hosting the conference today alone, since my colleague Marjo Näki had to go back to Moscow, where she's working as a journalist for Finnish television and radio. And before we actually start, we have some more reminders to you. As usual, the sessions will be in 3 rooms. This is the main room, engine room. The room's name is always on the lower half of the screen, and the other rooms are downstairs. So you'll find the room where the session is, since we have 2 big sessions here in this hall, the first session and the last session today. Other sessions are all 3 sessions at the same time. So the breaks are all downstairs, the main floor where you entered. There is food, there are all the facilities, toilets, etc. So you know that. And we also ask you to connect to the internet here at the conference, since, as you know, the conference is paper-free. The connection is through the data link, and password is 5th freedom. That's a freedom that is very important for Estonia during our presidency at the European Union to advance the digital freedom here. And we are asking kindly you to log to the site delegate.eu2017.ee to find more information on the conference and provide your feedback. And you can also give us your feedback and discuss the conference on Twitter. And now our first speech today. I'm really happy to welcome on the stage former Prime Minister of Estonia, Mr. Taavi Rõivas. He was invited here because during his time in office, he really advanced the Estonian digital agenda. He advanced our cooperation with Finland on that field, and as we have noted several times here, since May next year, you can fill prescriptions that are written in Estonia or in Finland, vice versa in Estonia or Finland. So this is really a great sign that we are cooperating on that field. But here is Mr. Rivas. And after his remarks, we have a quick Q&A session, please.
Thank you. Thank you very much, and good morning, everyone. Good morning. You wouldn't probably be here if you wouldn't believe in digital disrupting healthcare. You wouldn't probably be here if you wouldn't understand that digital is the biggest thing today, not tomorrow, today, that is changing our lives. There are many people still around the world who think that we either might or might not go digital in some sectors. Some people think that we might not have self-driving cars. Some people think that we might go along for 10 or 20 years without digital identity. I don't think this is the case. I think the digital identity, digital disruption is here already. And the only difference is which countries, which organizations, which hospitals, which ministries are on the front line and actually using this disruption to change for the better, to reform, to have a positive disruption, so to say, and those who lag behind, believing that you can stick to the past. Now, the only main thing, and by now you probably know that already, the only main thing that we have different in Estonia than many other countries is that we actually use our digital identity. Most of you who are from EU countries actually have something similar at home. And I'm not telling you a big secret if I tell that Estonians were not the ones who invented that. Finns were. Finns invented that in the beginning of this century, and we started using that at around 2002. And the difference was, and we started using that. So that makes all the difference. So today, this is the biggest enabler to create all the digital services in Estonia. And I'm not only talking about healthcare, I'm talking about how to sign documents, how to identify yourself. Think of it as, think of the world where you only have cash. If you only have cash, you have no way of ordering anything from eBay, right? You need to actually travel there, hand out the cash, get the package, and then you get some transactions done. So this is, in a way, something that enables to do the same thing with your identity as credit card or PayPal or whatever format is doing with your wallet. Now, let me give you another example. Just to get a letter from here to the United States, or a message, took a couple of hundred years ago, took tens of days. Today, it goes instantly. But what about a legally binding contract signed by two entities? It still takes, before becoming a prime minister, I was a health minister. Every single week, I had to sign a pile of papers, every page. Those were the contracts of what the price of particular prescription drug in Estonia would be. I had to do it like that. Often the companies headquartered in Amsterdam, Berlin, US somewhere, they sent those packages by mail, taking days, weeks, whatever. Now, the other way of doing that, and you probably know that by now, but just to remind you, the other way of doing that is going digital. And instead of just scribbling something in the bottom right corner of the paper, you actually properly, digitally stamp this document in this way that nobody can modify that. Can anyone in the audience raise a hand claiming that you know what my handwritten signature looks like? No? Oh, there's one. Okay. I don't see it there, but you probably were my colleague at some point or are still. So, okay, one person out of 150, 200, what is here? So, and even she who raised the hand probably doesn't know if it was actually me writing that signature or was it my assistant who is getting very good at that. Or was it my daughter who actually wanted to, some of us have done this thing that you write to the teacher and then sign on behalf of your mother and then, get along with that. And imagine the same technology, pen, paper, scribbling, the same technology of the, I don't know how long times ago, we still trust in contracting ourselves to hundreds of thousands, millions, sometimes even more. Does it sound particularly safe to you? Not to me. So those who say that digital is not safe, I would argue otherwise. Digital is so much more safe. And in Estonian version, we have the 2048 bit key on that, which is basically taking quadrillions of years for one single computer to crack. So if you don't have quadrillions of years, you need more computers than anyone actually has to actually crack this signature. So in this, or hack this signature. So in this principle, I think, if you compare the handwritten version to the digital, we have a big difference. Now, you probably know by now that for quite some time, around a decade, in Estonia, all the medical data of all the patients is in one single database. And this is not so unique per se, because many hospitals around the world have something similar. What is really truly unique is that this is nationwide. So any hospital in Tallinn, in Tartu, in Põlva, the small ones, any hospital, any family practitioner, if they have me as a patient visiting them, they write down what they observe, what they think, what is necessary to prescribe me any drugs, whatever it is. They put the case summaries there. Which means that if the patient is taken to another hospital, which sometimes happens in the case of emergency, the doctor already knows a lot. And again, you wouldn't be here if you wouldn't know what it means if the doctor knows more about you. You don't need to rerun all the tests. Sometimes radiology tests might cost a lot. Sometimes even more than the cost is what the time they take. So in principle, it's not only about the saving time and hassle and money, but it's very much also about the saving lives. Having the data about you is helping the doctor. And this is the general presumption in Estonia. Now, of course, anyone, any politician, any doctor, any journalist that I have ever shown that digital patients portal or digital healthcare of Estonia to has said that, what about privacy? What about some journalists go snooping around and seeing whether my knee is hurt or not? And this, let me state, is the most important question there is. People are very sensitive about their health data, and rightfully so. So what we have done to safeguard this data is that any patient can themselves log into the patient's portal if they see anything that is either irrelevant to other doctors or something that you consider sensitive. With one click, you close it and no doctor sees it. The second thing is the doctor himself or herself has to log in as well to see any of that data. So basically, nobody else who isn't a certified doctor can look at your health data. This is one thing. No journalists, no official from Ministry of Healthcare, no one. Only doctors. But even there is very important to keep in mind that if a doctor is looking at some data that he or she doesn't have any reason to look at, they are most certainly, violating the trust. And how do I, as a patient, know that who has looked at my data? Very simple. We keep logs, and every patient can look at any time. So basically, if my dentist is looking at my knee surgery operation or information, that's and this is published in the newspaper, even if it isn't published in the newspaper, that is an issue, and I can press charges. So simple things sometimes make all the difference. And with that, I would argue that we have gained a lot of trust by the Estonian people to this system. And wherever you live, please don't tell me that this isn't possible in your country. Just come to me and I will argue otherwise. We are not some sort of, digital people or only digital people here in Estonia. We are normal people. We think the same way as you do. But we simply have kind of tested, we have pressed forward, we have enabled the digital solutions, and that has helped quite a bit. Now, of course, I'm not here to describe what Estonia has done and to brag about Estonia. This is not the task here. My task here is to think together with you what actually can be done when we have digital identity, when we have digital infrastructure, and when we have data that actually doesn't have any borders. The password of this conference, Fifth Freedom, is something that is extremely important, not only for Estonia, but for all of EU. Because in theory, data is the easiest to move. Moving one email from here to Finland takes you milliseconds. Moving it to Portugal doesn't take much more time. So in principle, it's easier to move data than goods or people or capital, but we all know that in practice we still have difficulties with that. Now, it was correctly said by our host Neeme today that we have this piloting program that together with Finland, it is possible to get prescription drugs in this way that you just go to the doctor prescribes the prescription or writes the prescription to the computer, and you go to any pharmacist, just identify yourself, show your ID, passport, whatever, and they will issue the prescription drug. And we will have that very soon in this way that any Finn can come to any pharmacy in Estonia, and any Estonian can go to any pharmacy in Finland. So that's quite convenient, right? Now imagine if any Brit can do it in, let's say, Costa del Sol, where I think around 1 million Brits live. So in principle, they can keep their doctor in London or wherever in UK, and they get the prescription drugs in their pharmacy. They don't need to travel. They don't need to visit a doctor that they don't actually know, or you probably understand the point. So in principle, our, I wouldn't say ultimate goal, but our goal in this should not be less than having digital prescription working across all the borders in all of EU. And of course, hopefully at some point also globally. And I don't need to tell you too much how much it would actually help getting the prescriptions you actually need. Now, one more thing about digital prescription. You probably know that already, that we have like close to 100% digital prescriptions, and this is not unique anymore because many of your countries have the same. One more thing that you have with that is you actually can use the metadata or the big data just to depersonalize it. You can understand what the population is consuming or not consuming, what are their behavioral habits, and you can actually make smarter decisions. When I was health minister, I also chaired the Estonian Health Insurance Fund, the board, the supervisory board. And there we discussed one particular thing that was very, very, very important and made all the difference, not only budget-wise, but health-wise. And that was the observation that we didn't look at anybody's particular health data, but we looked at the overall thing that how, for example, retired people consume their drugs. And what we found out, that was back in 2012 or 13, what we found out was that they don't trust generics. For some reason, in Estonia, the general presumption in 2012 and 13 in the population who was like 65 plus or 60 plus was that generics are like fake or not original or second best or not helping as much. So in order to, and you of course all know that this is not the case, in order to actually change that, the Health Insurance Fund ran a campaign explaining that the molecule is the same, and this is up to you to decide which brand you choose, what are the differences, and look also at the price. And I don't have to tell you that this saved a lot of money, not only for the people, but also for the health insurance funds. And if you think how much data we actually collect from all the people, on paper, digitally, in all sorts of ways. And if we go to the next level and add behavioral data that people themselves connect, for example, with my Apple Watch every day, this is amazing how much we actually know about people's health. Now, let's go one step forward and think about genomics. If you actually, at one point, sequencing genome is, I would believe, affordable. It's actually rather affordable already, but it will be probably much, much cheaper still. And if you have the data of everybody's genetic information also at some information system, of course, securely, then think how much conclusions you could pull either from this person's health data or from the population as general. So, in my opinion, that is about to change the way we treat people in healthcare quite a bit. Those of you who are doctors probably know that it's not that in today's world we can cure all the diseases with penicillin, or there isn't like one specific drug fits all the people even in the same diagnosis. So again, if we collect more information, if we learn to make smart use of that, and digital is the only way of doing that, not the piles of paper somebody is analyzing in any way, then we probably can get so much more precision drugs, and we don't have to try to cure anyone or everyone with the same medicine. A lot of people have asked me, what about digital divide? What about old people who cannot actually use computers? Well, I think that is about to change. I think, first of all, today's generation of old people actually already use some sort of computing devices, not necessarily PCs, but you don't need to use PC in order to use a computing device. Today's computing device is iPhone, is Android phone, is your watch, is your, I don't know, what will be in a couple of years, your necklace. So in principle, using a computing device actually doesn't need any special knowledge anymore, which means that the digital divide will, it will not go away perhaps, but there will be much less of digital divide. A wise man has said that education is the biggest equalizer in the world. I would add that in today's world, digital is the second most important. So giving you access to information, giving you access to services is greatly extended by the opportunities that digital actually has. Now, one more thing about getting your health data there in the digital world. Most countries, as I said before, say that, yeah, this is Estonia. This is some sort of model somewhere in the far north. Okay, they can do it. But, there is, in our country, the culture is different. We need to, take care of privacy, or we need to take care of security. Guess what? We think the same way. We think of security and privacy all the way through designing all those projects. And perhaps we have a bit more time to discuss today. If anyone has a security question, I promise that I will make this kind of examples that actually show that digital healthcare system, digital patient data is so much more safe than the one on paper. Actually, the only ones in the room who know that your family practitioner or somebody at your family practitioner's office is not looking at your health data right now, for sure. The only people who know that for sure are the Estonians in the room, because we can easily log into the patient's portal and see who has looked at which page of my health data, at what day, at what minute, at what second. But do the Frenchmen know that? Who is looking at your Poles, Finns? Do you know that? So think about it. sometimes it feels safe to have something solid on the paper. But if you really start to think about it, something that is really safely secured in the digital world, and if there are safety measures like logs, like secure logins, like all the procedures around that, digital might be so much more secure. With that, I thank you for your attention. Thank you very much.
And now I have time for a short Q&A session, but I would like to start with one question that we Estonians are very often asked here at the conference. How has Estonia achieved this trust in the digital system? How the citizenship has, how we trust the system, how we are sure that this data is secure and it's not improperly used by anybody?
Well, I think there is no one secret sauce or secret recipe in that. I think if you use some sort of services on a daily basis and you see that nothing has happened for 10 years, for 15 years to anyone, then the trust increases. Let me give you an example that all of you trust. All of you trust your money to internet banking. This, by the way, is digital as well. ATM is digital. So it's not about handing out cash physically, just any person physically IDing you. And we all know that this system works. And this system, or this, ATMs and credit cards and internet banking is actually not the best example because it's much less safe than the Estonian digital ID. So I believe that the trust has come with time. The trust has come with also the safeguards that I explained, that people themselves can look at what data government or any institution has about them, and that sort of helps to gain the trust.
Although we know that the hacks are taking place every day, and Estonia has this dubious fame to say that it was one of the first countries, probably the first country that was really the object of an internet war. That was 2007. Now this attack probably from Russia, we don't know for sure, but we suspect, seems very small, but in every article about the cyber wars, Estonia is mentioned again.
Well, I think that was a proper attack, and that was...
And the banking system was attacked.
Exactly.
In particular.
But what actually happened, that was a DDoS attack that halted the system at some point, but at no point anyone's data was kind of seen in terms of violation of privacy. And which is, of course, even more important, no data was modified. So basically, you can attack the bank's server IP address in this way that you shut down the internet bank or the web page of the bank, but you cannot change the amount of money that I have and change it to some other political leader in some less democratic country might have. So that cannot happen, and that's, I believe, very positive. And the same, of course, is in health. Privacy is very important. If somebody, this is an exception that, or the example that is made by our previous president many times, and I quote Thomas Ilves saying, if somebody looks at my blood type and publishes it or sees it without reason, I might be angry at that. But if somebody can actually change my blood type in this system, that is so much of a bigger problem to me. And think of how easy it's if somebody wants to violate my health or wants to harm me, then changing from A- to A+ is not very difficult if you have the paper file, right? In digital, this is not possible. And again, one example why digital is more safe.
Mr. Ilves addressed our conference 2 days ago, and one of his messages was that Europe has to move faster on the digital road because he was heading the task force, as he said, in the European Union on that topic, and it took 5 years to implement, for example, this Estonian-Finnish cooperation on prescriptions. But we have time for some more questions. If anybody has questions in audience this morning? If not, we are ending this session.
Yeah,
there is one question, please. Wait for the microphone and please introduce yourself.
Thank you very much. My name is Silas Olsson from Sweden. Thank you for a very good and interesting presentation. I have a question about when you have this very nice and very wide system in Estonia, how about the cost? I mean, have you yet see any, let's say, reduction of the public cost for the healthcare system? You mentioned the pharmaceutical. The cost there has dropped, but above that, for other kind of services, have you done some calculations there?
Well, the gentleman in the front row who is in charge of e-health, Aino Aaviksoo, is probably better to answer that if we have analyzed this reduction of cost recently. But one more example, in addition to prescription drugs, is not doing the analysis again. So if you are taken care of in a small hospital and they say that your status is difficult enough to go to a bigger one, then they immediately have the access to all of the studies that have been done or all the x-rays and so forth that have been done. So the cost for the system is not doing that, or the reduction of cost is not doing that again. Now, please understand, Estonian system that we have today is still scratching the top of the iceberg. The potential is a million times bigger. Just one thing, how do you book your hotel room when you came here to Tallinn? You probably, or when you go to a vacation, let's say, you probably take an app, perhaps Booking.com, perhaps Airbnb, something like that, and at any location in the world, you can book a hotel room, right? You can see what are the availabilities, you can see what is the cost. Now, how do you book your doctor's appointment? If you would like to have an eye doctor or whatever practitioner, like let's say in a range of 50 or 100 kilometers from this spot, you call to all of them, like 200 calls. Are you ready for that? So tell me one reason why I couldn't have a state kind of built booking system for finding myself the first eye doctor that is available around 100 kilometers from this spot. That's a food for thought, right? So Estonian system is probably one of the best in the world, and we have innovated a lot, but I think there is so much we could do, and there's so many countries that we have to learn from who have actually found very, very smart ideas how to do that.
It's interesting to see how the countries in Europe will compete with each other, because as we heard yesterday, Sweden has decided, the government, that Sweden will be the best country on internet technology at 2025. So.
Yeah, and I believe if governments have that kind of approaches, they have a good chance to actually getting there. But the countries around the world, Singapore, Dubai, they are investing a lot to use new technologies, not only in healthcare, but around the sphere. And I think we should keep our eyes open, start using those technologies, also that somebody else has innovated. It's not like, Estonian technology can only be used in Estonia, or Swedish technology or Swedish ideas can only be implemented in Sweden. Digital, in theory, doesn't have borders. So internet is universal in a way, and we don't need to think that we are all so unique that we are not we are too posh to look at the Swedish example. We are not. We should look at the Swedish example. We should take the best practices for that, and also from Dubai and Singapore and other countries.
And for this conference, important thing is to see the connections between European countries, because our aim is to have this one and not divided Europe on digital field also. Any more questions? We have now 10 minutes to divide ourselves into 3 sessions in Engine Hall here. As you see, will be session about My Medicine, My Way, and other sessions will be in Power Station and Steam Room. So 9:45 we'll continue our discussions. At 12:30 we have the final speech from Estonian President, Ms. Kersti Kaljulaid, here in the main hall. Thank you, Mr. Rose.
Thank you very much.
Thank you.
Ladies and gentlemen, welcome to this session, My Medicine, My Way, the role of personalized medicine and genomics. My name is Helmut Brandt and I have to declare myself I'm e-citizen of Estonia. So I'm a little bit biased. The first job I was asked to do to remind you to switch your mobiles into the mute status. Second is there is a survey on the presidency gateway that you please fill in as a kind of feedback to the organizers. And if you don't give them 5 stars, you get in trouble with me, because I really liked how this conference was organized. Personalized medicine, is this the next big thing? Can we create out of big data and genomics the holy grail of internal use? And can we move from precision medicine to personalized medicine? Will this be a disruptive innovation? And disruptive innovations always are at the edge of legality. Uber and Airbnb challenged the law. In some countries, Uber is illegal. So what will happen to personalized medicine? Where are the boundaries for this? I'm now 60 years old, so I'm looking very much ahead that this personalized medicine will be delivered when I need it. And watching Estonia, I wondered, why can they make such a big progress? I think there are a lot of reasons for this, but one underlying reason is that they have young people being in charge. I never saw so many young professionals being in charge as ministers, prime ministers in this young age. Perhaps this is one of these reasons why Estonia can walk ahead, giving the lead, because they really give young people a chance. But now, let us come to our session. We will have 3 interventions, one that is explaining a little bit where we are, and 2 examples what kind of infrastructure we will need. And as first speaker, I would like to ask Ain Avixo from the Ministry of Social Affairs to explain us where are we at the moment regarding personalized medicine.
Thank you, Helmut. For those who were here yesterday, today I have my own iPad with me so that I don't have to look for. We in Estonia, we can't be with our digital devices. I will speak about, I'm wearing 2 hats at this moment. First is really my daily job here in Estonia as a Chief Information and Innovation Officer at the Ministry of Social Affairs. But I also have started to love the work I have had an opportunity to do at the European level. So there is an initiative that I'm going to talk about at the European level, which actually can contribute to all of you to do the same as we have been implementing here in Estonia. And the title really is with a question mark, and I hope that the following presentations also give you a little bit of glimpse what are the building blocks, and then in the discussion we try to connect them together with an interactive discussions with you. What do you think, how we could make the developments faster? First, I'd like to start with the statement that, again, as Mr. Brown said, the question is not if. The question is how we're going to deliver that. It has been expressed and is practiced, not in Estonia, but in many other countries already today. We want personalized medicine. There are council conclusions from December 2015 when Luxembourg held the presidency. Commissioner Moedas, half a year later, expressed again, better health for all, 1 person at a time, is a slogan that we should start working together. And then you can see that Estonia, but also England, Finland, France, well, if I would have bigger slide, I would have probably, at least I have awareness of around 10 specific large-scale genomic or personalized or precision or anything which implies that same size fits all type of healthcare is not anymore neither ethical nor affordable to our health systems. At the same time, down on the ground, in addition to national efforts, there are also several international efforts that I think some of you are part of and others have heard of them. European Medical Informatics Framework, initiative funded by Innovative Medicine Initiatives. BBMRI has several projects, so this is the collection of biobanks. There are cohorts in BBMRI LPC that work together. There are other types of specific genomic collections that work together to find new solutions for health problems, looking at genomes, but across many other countries, many countries at a time. In Estonia, 16 years ago, we started our genomic bank. 5% of adult population voluntarily donated their blood, gave broad consent to combine this genetic information with their health data. And today, this biobank is, I would say, the powerhouse of academic research in Estonia. They publish on a weekly basis in Nature and Science and all other journals. And we know, and people have learned to support that. When we started, 18% of people in a population survey were comfortable with the idea that their genetic data would be combined with their health data and then analyzed for research purposes, and with the promise that at some point they might also get individualized advice, because they were explained that it might be that we don't know yet what your genome will tell about you. This is what we're going to start working for, and if we find something that is practically useful to you, you will get that information back. And people are liking this combination of contributing to the research and also getting individual advice back. So when we started 15 years ago, the percentage was 18. Last year, the percentage was 70. So again, if you recall the keynote speech from Mr. Taavi Rõivas, and when he said that, well, we do trust and we have started using them, this trust has been built over time, and this is also with a personalized medicine. I have also on the right-hand side of the slide, very interesting initiative, again funded by IMI, with the broad umbrella, Big Data for Better Outcomes, but the small logos there represent specific disease groups that are being targeted in a way where data across Europe from different research centers or university data banks or hospitals are collected together and analyzed to find the solution for Alzheimer's disease, cardiovascular diseases, or blood cancer. And then there is a research and innovation action which has been called to build European Health Data Network. The call will close, I believe, next week, and I hope that there will be a good consortium. And then there is in the middle IC Pyramid, which I will tell a little bit more now. IC Pyramid is an international consortium of country or national funding agencies for personalized medicine. It has 13 European and international partners. By the way, Canada is a member. There is increasing interest from the United States, from China, from South America. So it has really proven to be one interesting model to cooperate, so that it is not Brussels. So we every now and then we meet in Brussels or other places, and there is a kind of framework and structure which enables us to collaborate. But it is really driven by the funding agencies who want to collaborate, say for instance, to form a research project which is interesting to Estonia, Finland, Germany and France, and then also the researchers can have more leverage and actually more brain power to work together. The vision is to make Europe a global leader in personalized medicine research. Currently, I know there is undergoing a study and there are first glimpses that might come out of that even though we spend public money into personalized medicine a lot, perhaps the efficiency or even, I would say, effectiveness, so the actual implementation of personalized medicine in the real world is not as good as we want to, and some other regions in the world might actually go quicker. So it is also supporting personalized medicine science base, but also supporting how the benefits of personalized medicine could be delivered actually to citizens and healthcare systems. So researcher as a driver of personalized medicine, but actually covering the whole value chain. So there have been thematic topics, so there are policy, how patients, how industry funders, so how each stakeholder group looks at what are their interests. Policy and politics is about interests. Indeed, industry is there because they have shareholders, they want to make money. And we don't need to be ashamed of that. And then there are public funders. A big part of healthcare systems in Estonia are funded by public money, so there needs to be a balanced way how to collaborate. And then there are citizens who want to get the best care at the time, as we heard, now what is available, and then there are researchers who are just curious people and will love to research. So they all have their own interest, but if we find ways how to make them work together, then actually it is possible to find that 5 win-win-win type of collaboration formats. And this is what the IC permit tries to deliver. Then we have data and ICT, then we have industry, and industry from the regulation point of view. So what is research? It used to be so that the clinicians do their clinical work, and then at some point of time, some patients would fill in specific form, and those would be enrolled into clinical trials. This is not anymore the case. Big data era, any encounter in health system is potentially a research encounter. And our legal frameworks, sometimes even our information systems, may not support that approach that well. We went through in Estonia a tedious process, and I'm really thankful to the very patient researchers who whole year negotiated with our ethics boards and then also data protection agency to tell and explain how we would like to work with all 1.4 million 1.4 million patient health data in our national health information system for research purposes, to find different patterns, to find things that we even don't know we're going to find from there. So even in Estonia, sometimes it takes time. Even we found out later on the legal basis is there. In principle, we do have the technologies, especially if we work together with the academia. Even the data governance models are there, but we just haven't practiced and used them. So again, referring back to what Mr. Talvi-Rivas said this morning, it is very important that we actually start using and practicing the things that we do have there. And then there is market access. It is not that easy to get those new solutions to get on market because they function differently. They may be costly upfront, but the business model foresees that the savings will come later, whereas our systems in health financing are usually built in such a way that all the risks have to be mitigated by the industry upfront, and then we divide later on the solutions being either original or generic, and then the cost difference between them kind of levels out for the whole system. This doesn't work for this kind of innovation. And then there is assessment, so that we actually know how these would function. So to cover all that continuum, personalized medicine IC permit is well, starting from making practical things. First, there is one call, first call that will come out already next year. Then there is networking of researchers and institutions. There are strategic recommendations And again, that is member state driven. So if some countries or regions are capable of working in certain way, again, this kind of clearinghouse tells this example to all others. How to facilitate at the system level and how to build partnerships globally and also in Europe. And it has a regular meetups. So please, I believe, in all of your countries, there is a representative belonging to the IC permit. In Estonia, we have two, both Ministry of Social Affairs, but also Ministry of Research and Education through their research agency, ETAC, are partners there, and we need actually input from researchers, either from the clinical side, IT side, or others, to work what is useful and beneficial for Estonia. And I will close or kind of finalize my first intervention by first making you a little bit envious. So we have in the United States already in 2015 declared by the president at that time to build a research program for 1 million people, combining their genetic data but all the health data, and to have this kind of huge personalized medicine data bank available. So, well, first through informed consent, people are voluntarily participating there, but then it is open to all researchers to find new solutions. Well, a year later, China, at a very high level, Politburo decided, okay, we will build something like around 10 million. Because we want to be bigger and better than they there in America. And they are pouring a lot of money into this. And I have had discussions, and I could put up a challenge. We actually can, in Europe, I believe, by 2025, or at least in 2030, have 100 million Europeans connecting their data and combining their genetic and all other data if we want to. And by the example I told you about Estonia, the willingness to participate in that, I wouldn't doubt this is just 20% of the European population. If we have the courage to do so. But research is not enough. It cannot be done alone. This is busy slide. And the main message of this slide is that it is complicated and it is complex. So there are different kind of barriers. They have been mapped. I have attended several meetings by researchers, by IT people, by policymakers. Each of them discusses, we need to deal with the standards and interoperability. We need to find ways how to solve the legal issue. Then we need to find ways to define what the research actually is and make those investments on ground in hospitals, in primary care centers, to actually get this small data in order to combine it into big data. So, because if the small data is of poor quality, you can't be making reasonable research out of that at the big data level. Those are kind of technical aspects. And then there are different levels. So the benefits, some of them will be read by health systems. Some of them, as I mentioned already, will be read by researchers. Well, companies will make new products, and obviously they expect to earn that money back. Society at large, people individually. But they are not currently streamlined into kind of strategic line of action. We have fragmented, separated projects. Data the same way. It is health systems data, research data. Some of the data we carry along with ourselves in our pockets, in our mobile phones. It is not connected very well. Legal framework. We have national laws, we have EU laws, we have also global regulations and agreements on, when it comes to standards. Research can be national. There's national pride. We want our universities to be good. We just heard Sweden wants to be the best. But we also need to work at the European level because, as I showed you, it is not for any country in Europe to be successful alone. Infrastructure, again, national, EU, global. Investments, private, local, national, EU, global. So it is a task for Europe. So while I'm very proud of Estonian Genome Bank. I hope in 5 years' time I can tell I'm proud of European personalized medicine bank or data warehouse or whatever we will call it, where Estonia is part of. And we have already existing players in the initiatives. We have a decision to establish e-health network. We have IC Pyramid, I told you. We have IMI. We have 4 different DGs at the Commission. The Commission very often is perceived as being kind of a homogeneous organization of Euro bureaucrats working somewhere in Brussels, or maybe some of them in Luxembourg. But actually, the task for Research and Innovation DG is really to pursue the research and the mandate, how they work and how they collaborate with the Ministries of Research in member states is different that of the DG Sante, which works also with the member states, but through the Ministries of Health, or in Estonian case, Ministry of Social Affairs. And then there is DG Connect, which collaborates with, in the case of e-health, with Ministries of Health, but also with the Ministries of ICT. And then there is DG of Internal Market, Industry, Entrepreneurship and SMEs, DG Growth, which is very much about making digital single market something that will prosper the economy. So again, we need collaboration in different formats. Yesterday you heard that Digital Health Society could be one very specifically action and outcome-oriented initiative that would help to bind those together. And my final slide is really for discussion. I haven't discussed that in details with anyone yet. It is a proposal. It has been discussed, let's say, bilaterally, but not as a decision. So already referred to that we should start talking more about European pride and maybe not that much try to compete between countries ourselves. I think there was a wonderful cover page from Economist at the beginning of the year, how the world is seen by China. And you know, if there was a globe and then Europe was somewhere, it's a peninsula if you look at the large map. So we need to start thinking as of Europe. We need to have a common strategic goal, a flagship goal. We could sign letter of intent by member states who are willing to start going now. As Tavire said, it's not about when, tomorrow, and then discuss. The decision first has to be made, let's start doing those things. Because we have things on the ground. We have people, we have technologies, we have legal framework, we have everything. We just need to start working. And then roll out. Coalition of the willing will start. Coordinated support. We can discuss that later on. This would be my kind of appraisal for the session. Thank you.
Thank you, Ian. Please, it's very good to have an overview about what's going on, and especially that it's a European task that we have to do. All these initiatives have to end up in some infrastructure that we can really use to make personalized medicine happen. And we would like to show you now 2 examples for this. The first one is here from Estonia, from the Estonian Medical Imaging Bank, Andrus Paats. I hand over now the pusher. He will show us how the Estonians solved this problem.
Good morning. I should also announce that I also working in 2 positions. I'm working in the biggest hospital in Estonia, in the North Estonia Medical Center, and also in Foundation of Estonian PACS. And during this presentation, I would like to explain you how is working Central Medical Image Archive in Estonia. Everything was starting in 2001, and it was funny name, picnic project between Sweden and Baltic countries. And purpose of this project was to implement telemedicine, teleconsultation. So Baltic countries hospital were provided with teleconferencing tools for starting a consultation with Swedish university hospitals. But it was one hospital, Tartu University Hospital, who said that please provide us also a small PACS system. And single server-based Aqua Impax 3.5 PACS system was delivered. And University Hospital was starting to provide DICOM archiving and web viewer services for all Estonian medical institutions free of charge. Years were going, it came out that performance was going down because the number of digital modalities was increasing. And University Hospital was extending the system, and they started ask the money for archiving. And the cost was €1 per study. But in 2005, the hospitals in Tallinn, we formed a consortium for purchasing other new powerful PACS system as an alternative for University Hospital system. But it came out that we couldn't handle it, this project, and we finished in 2005 in a contract between University Hospital and North Estonia Medical Center for establishing a new organization called Foundation of Estonian PACS. In Estonia, it's a pillibank. And the purpose of this organization was to develop and manage one common environment for transmission, archiving, and usage of medical images for all Estonian healthcare institutions in equal conditions. This equal conditions is very important because there were hospitals who are thinking that these two big hospitals made this project for getting money for smaller, for financing this project. But actually, it was wrong because these two big hospitals were using 50% of capacity of the system. And it was important that these two hospitals didn't fight with each other, but they integrated technologies, images, resources, people. And it was important that the same people who worked in hospitals, they started also to work in the new organization. And the organization itself was small. It was less than 10 persons. The next important date was in 2014, when government authorized Foundation of Estonian PACS to act as a central medical image archive. And in 1st September of 2014, every DICOM image made in Estonia should be archived in this system. Unfortunately, state stopped financing in 2016, but it was a good beginning because we had a negotiation with Estonian Health Insurance Fund, and they started to finance archiving. So currently, archiving is free of charge to every medical institution in Estonia. What is the technology behind of the Central Medical Image Archive? It was planned to be as a central PACS system, and every modality was connected to this central PACS, or the hospital who had a PACS system has capability to connect the PACS system to the central PACS system. But behind of a central PACS system, there was the long-term archive based on DICOM standard, and all this technology was distributed between two sites, between Tallinn and Estonia, located in distance of 200 kilometers. For accessing the images, the easiest way was to use our portal system, what was integrated with HTML5-based web viewer. And the network, how we were getting the images. Unfortunately, we couldn't use the famous X-Road system because X-Road is not supporting the DICOM standard, but all imaging modalities are speaking. So we built up the VPN-based private network, and every hospital who is making images is actually connected to the central system via this network. But for image sharing, what is done web-based, we are using the secure SSL protocol. We are able to collect all modern imaging modalities, and starting from X-rays and finishing with positron emission tomography. And we even scanned important old plain X-ray films. So our archive includes also some old X-ray films. And additionally, there is capability to store the photographs taken from normal cameras or mobile phones, and also store the videos. And what is very important is that radiological studies are connected with radiology reports. So if you're opening the images, you also can read the report. And a couple of years ago, we started to archive ECGs. And we are doing it in numeric format, so there is possibility to analyze them later and not to treat them as a PDF image. If you're looking the volumes, we can see that in the beginning, there was quite small number of studies came to archive. But one big jump was in 2006, 2007. It was a time when a new PACS system was installed. And the next big jump is actually in 2014, 2015, where actually state was starting to demand that all images will be archived centrally. And if you're looking, when you can see that in 2016, we had already over 10 million studies archived. I was making the query on last Friday, and I was surprised that the number of studies archived in our system was over 12 million. And if you're looking the amount of data, there was 820 terabyte non-compressed data in our system. There are different ways to access to the central archive. Usually it's done via portal, via integrated web viewer, and this portal is usually integrated with all healthcare providers' information systems. So you don't need to log in separately. You can just go smoothly from one system to other, but there is also possibility to use personal accounts. And there is also possibility to use TICOM protocol for hospital PACSes, for hospital TICOM workstations. But what is important is that data access to this image archive is granted only to healthcare service providers who are signed our contract. And this contract says that this data is allowed to use only for patient diagnostic and treatment purposes. If you're thinking to the future, there is a huge amount of data currently available. So it is a good idea to use it for science and research, but there are some prerequisites. So for us, the most important is the legal rights, because currently it is not clear that can we share this anonymous patient data with others or not. And second point is resources, because current system is optimized for daily clinical work. So if there will be new applications, there will be also needed extensions of the system to share this huge amount of data. And of course, it needs extra finances. In conclusion, I can say that images of Estonian people are archived centrally. And what is very important is that they are accessible by personal ID, which means that it is a good beginning for personalized medicine. So every Estonian person's images are available for in the future and in the moment already to the doctors for personalized medicine. And for sharing this data for science and research, we already have data, we have knowledge, and we have people, but there are missing proper legislation and additional financial resources. And it is clear that this service cannot be free of charge because it's actually quite big amount extra work compared to the current situation. And if there is something to learn from our experience, I would like to point out that what was the base of this success of this project? It was cooperation between different healthcare providers. And it was important that initiative came from down to up, not from up to down. Thank you.
Thank you. So, Estonia invented the flicker for radiology. Everyone can have a view on his own radiological prints in a way. And we now have even an estimate, 1.3 million Estonians and 1.4 as you call them, studies are done per year. So one per each person. So we saw the first example, what kind of infrastructure you need, but where do the patients come from? How to find the right patients? And there, Tigran Atsumanov from Clinerion would like to show us what they developed, how they solved this problem. And I hand over the switcher for you.
Well, hello, everybody. Thank you for welcoming me to this conference. We have a very interesting and unique perspective, I guess, coming into this event. We are a private company. And we were formed for a very specific purpose. But first, I'll give a bit of a general introduction. Now, we talk about personalized medicine. In Clinerion, we think that personalized medicine is a subset of precision medicine. So as we work in healthcare and we try to optimize the treatments, we are forced to look at smaller and smaller cohorts of patients. And eventually, these small cohorts of patients are going to become a cohort of one. And this is when we will be at the edge of personalized medicine. But there is some work and some time to get there. And we are a private company that's doing our best to bring this reality closer to the present. And we are doing this by finding patients for clinical trials. So as opposed to public initiatives that often have very wide scale and very ambitious goal, we as a humble private company are trying to be very focused and deal with something very specific. So we started by looking for patients for clinical trials, and we do this by collecting data from hospitals and using this data to identify the right patients. And I will give you a quick example to illustrate better what we do. So we ran a study in dyslipidemia, which is a common disease, and there are lots of patients diagnosed with this type of disease. However, this particular study had around 40 inclusion-exclusion criteria, and patients had to be included into the study within a few hours. So these type of studies bring huge challenges because usually hospital staff struggle to check 40 inclusion-exclusion criteria, as it takes a lot of effort. And if the time to do that is limited, then often such a study becomes not feasible. So we were able to identify the study population very quickly, we saw that there are around 100 patients per million for this study, which was spread across our network, and we were able to successfully enroll them. Now, I will spend a little bit of time to talk about two themes that I think are common for everybody who is trying to make a mark in this space. And one is data. Data is paramount for precision medicine and for personalized medicine. Without data, it is not possible to operate in this space. And another is legislation. I always give an example when talking about privacy, about something that I learned about Estonia when I first started dealing with Estonian colleagues. In Estonia, every citizen can opt out of sharing personal medical data to anybody other than their treating physician. And such a citizen will be warned that if he or she is picked up by the ambulance, and if sharing is not allowed, then the ambulance will not be able to see the data on allergies, and he or she may in fact die because of that. So you can see that in this case, excessive privacy may lead to patient harm. And regulators are often going overboard, thinking that privacy is always good, but it's not always the case. And this is why technological solutions that work to increase privacy can be very good for research and for patients, because in some occasions they're able to increase privacy without coming up with the side effects which may in fact harm a patient. Now that I have explained how we work, I will spend a little bit of time to show how we actually do this. We come to a hospital and we offer our system at no cost to the hospital. So public research depends a lot on money, and we just heard that certain things cannot be done for free. Being a greedy private company, we are actually able to offer something for free, which is quite unique. And of course, we are able to do this because we have shareholders that think long-term. So we come to hospitals, we offer our hardware and our software, and we install our servers to stay in the hospitals. And the reason why we do this is we want to scale globally, and we want to give hospitals reassurance that their data is not leaving their premises. And we also want to have some insurance against future legislation changes, because many countries are declaring that data of their citizens should not leave a certain geography. Sometimes it's a country, sometimes it may be a region. In Germany, there are Bundesländer that also have own laws. So we think that if we have the data residing in hospitals, then we are secure against any change that limits spread of data. And after that, we gather the data from hospital information system, we process it, we make it searchable, and we are able to run queries which are based on clinical study protocols. Once we identify which hospitals have the patients, we are able to attract a clinical trial to that particular hospital, and later on, we give the hospital a tool to identify these patients. Now, we have here a challenge, and the challenge is identity management, because this is a very hot topic in legislation today, and with GDPR coming in May 2018, it is an issue. Historically, identity management for this type of application was handled through pseudonymized data. Pseudonymized data is essentially a case of fake IDs. And everybody who has been involved in clinical trials knows how this works. You are not allowed to disclose the identity of a patient to a pharmaceutical company. Their name should not feature in the reports, yet somehow you need to make sure you are talking about the same person. So the participants of the trial are assigned fake IDs, which are going to be used as part of the trial. And somewhere in the hospital there will be a list which will list all the fake IDs and all the corresponding real names. And something similar was used for applications such as ours. So there was a list which was electronic and was managed electronically, and every patient would be assigned a pseudonym, which would then make its way over to the server. And when there would be a need to trace back the patient from whom the data came, a request would go back to the hospital with the pseudonym, and then software would replace this pseudonym with the real patient ID. Now, the problem is that GDPR defines now pseudonymized data. So before, companies working in the field were able to make the argument that pseudonymized data is as good as anonymized data. And they even came up with a word for it, de-identified. It's a very nice word, it's a very amorphous word, it gives you reassurance. However, unfortunately for these companies, GDPR now defines pseudonymized data, there's a legal status for it, and GDPR very clearly states that such data are not, in fact, anonymized. Such data are considered legally private personal data, which means that all the restrictions that come with such a status are automatically assigned to such data. So what to do? And we were faced with this dilemma that it's becoming harder and harder to push the technology, and hospitals are raising questions. And legislation is only half of the problem. The other half is that hospitals become suspicious because they don't have the clarity. And instead of proceeding with something which may not be even permissible in the law, they play it safe. They play the waiting game. So we came up with a technology of using anonymized data for patient identification. Now, sounds very counterintuitive, but it does in fact work. So how does it work? And I first will give you a simple explanation and then a more detailed one. Think about Facebook. Facebook can identify pictures. When you upload a picture of somebody on Facebook, it makes a suggestion and says, this is in fact such and such person. How does it know? It knows because it has previous pictures of that person and it has the name of that person, and it's able to make the comparison. So we use the same principle. We work now with anonymized data. We identify records of interest. And when we want to establish the identity, we are sending the whole anonymized record to the hospital. And then software which we provide to the hospital compares anonymized record with the source record of the hospital. Now, because records are digital and because hospital is the place from which the data came, hospitalism is able to make 100% precise identification of that person, and the whole record now becomes identifier of a patient. Now, the biggest consequence of this is that data that we use in our server is now anonymized, and it's legally anonymized, which means that it's not subject to privacy regulations. This gives hospitals a lot of reassurance, so they know that anonymized data are safe for research, and they no longer feel threatened by the fact that they are giving us access to anonymized data. In this way, we are able to bring opportunities for clinical trial participation, for innovative treatments to patients who would otherwise be denied this chance, and we are not compromising their privacy. Now, for those people technically minded among you, how does this work exactly? We get anonymized data from the hospital infrastructure. All the personal identifiers are removed. The hospital calculates a storable string, and for example, this can be checksum, which is a string of characters that is uniquely linked with the data entry, with the record. Even if one byte of information is changed, a checksum changes. Then we encrypt that string, and we encrypt the original database identifier of the person, and hospital stores encrypted values. Now, once we identify the record that we want investigated, we send it back to the hospital, and the hospital recalculates the checksum based on the record that it receives, and it makes the comparison and retrieves patient ID by matching strings. And we even have a tool in place which allows us to keep identity of a patient for longitudinal studies. So we are able to establish that this is the same patient by asking the hospital to send us the last known record so that we know which patient we are talking about. So, in conclusion, we are a private company. We are doing our best to advance personalized and precision medicine. And we are dealing with different realities to the ones that we heard about. We are Swiss, which kind of makes us European, but not completely European. And we are looking at the whole world as our market. So we are very happy to help Europe to achieve its goals, but we are forced to look at the whole world. And we know that other countries in the world are actually not that much more open than Europe is to data sharing. There is United States, which is a completely separate case. But if we look at Japan, if we look at Asian countries, with the exception of Korea, they are very conservative as well. And they need help, they need technological solutions to make them part of the global research movement without compromising their privacy. So it's a big world, and the analogy that I have in my mind is that we are trying to build a park, and the park may be the best solution, but what we end up with is a forest, because we have different players from different sides, from different corners trying to do their own thing. And a number of players are necessary to make this work, because if we try to rely on creating a park, it's going to take too much time and too much effort. So we are trying to do this one tree at a time.
Thank you. Thank you very much for this intervention. And now it's time for questions and answers. We have a mic coming around, so who wants to start? The gentleman here in the front, please. Can you please tell who you are and whom you direct the question to?
My name is Jaak Vilo. I'm professor of bioinformatics at the University of Tartu here in Estonia. My question is about PACS system. As you know, the artificial intelligence has done huge leaps in especially image analysis recently. What is your take on research on image archive that would automatically help to tag the images on the archive? Is that research or helping the patient? Because we can help you. We know how to do deep learning, and the question is how to get data in the way that we can apply these technologies. And the second half of my question is, what about pathology and microscopy images? Do you also plan to have anything on that front?
Thank you for this question. It was coming very right time, because last week I was getting 3 calls for getting access to our image archive for implementing artificial intelligence. There was different companies. Some of them wanted images for making development. Some of them already had product and were ready to offer us a different product for implementation. And second part, for digital pathology, we planned it. We just replacing our long-term archive, and it is dedicated for 10 petabyte. And it's planned for also digital pathology. But currently, the problem is that if you're going to any Estonian pathology department and raising the question that are you ready for digitizing the pathology slides and taking into usage the digital pathology tools, when answer is that sorry, this is too early, it is too expensive, and if there is somebody who would like to finance it, they are ready to do it.
Okay. Please, the lady in front.
Yeah, thank you very much, Angela Brandt. When I found it very interesting, the idea you had for a flagship on personalized medicine. And at the moment, there's another call for the flagships in the DG Connect and also covering the topic of personalized medicine. Or is your idea more what had been, I think, the success story of Permit and IC Permit to involve from the beginning all the projects and then the initiative build it on funding bodies, member states, ministries. So would that your idea be of a flagship? Because I think that would be really unique.
Thank you, Angela. I even find a little bit, first, the idea hasn't been thought through to its full detail. So what I've heard from the conference here and discussions before that and in the corridors is that we need a good narrative. Because the specific pieces that we hear are there, and in order to combine them, those people who make decisions, I mean, they can't really follow these kind of technical bits. They understand that this is probably interesting, but the alternative cost for them is investing, for instance, a next railway or a next collider of electrons and all that stuff. So to have 100 million European data combined. And this is a very good question. I would at least put on table that to differentiate between research and clinical use for finding the patterns in the clinical world, when we have that algorithm already there, it shouldn't, at least for the start, to make this distinction doesn't seem relevant. I know lawyers would immediately tell that those two domains, come from the very difficult philosophical basis back to the conventions in UN and all that. But I also happen to know that some countries in Europe have been trying to find ways how to define that, combining legal framework, technology, and the data governance that can marry those two. So, in short, 100 European genomes working together, a FED flagship project in Europe, and then specific projects implementing that, including finding patients across Europe, including finding patterns from images in Estonia, but I know there are similar kind of PACSes around Europe.
Tigran, just imagine your system would be implemented in whole Estonia, in all hospitals. Wouldn't this put an end to all privacy? Because you could re-identify any anonymized patient file having some of this criteria from the patient file in the hospital?
A very good question. Now, the I guess advantage of our technology is that it can only be used to identify the patient at the hospital. No one else can do this because the source data is at the hospital. And the hospital knows who the patient is anyway. So usually this such identification has to happen as part of a research project. So anonymized data is used to see feasibility of a project, and once ethics committee gives go ahead for the project, then patient can be identified and contacted. So I'm afraid that patient data is just as secure as it has been.
Okay. Yeah. Thanks a lot for all your interventions. The discussion was a little bit short, but at the moment, the coffee is waiting for you. And as you know, the most important discussions are at the coffee table. Thank you very much for being here. Enjoy the rest of the conference and fill in the feedback form. Thank you very much.
morning, ladies and gentlemen. It's still a morning, and a good one. I'm very pleased to welcome you to one of the last sessions before the closing keynote, which will take place in this room. So please stay here with us until the very end. The session is called Integrated Person-Centered Care Innovation for Aging and Chronic Diseases. Apologies for the long name, but as you all know, integrated care is a very complex concept anyway, so we struggled to make it simpler. I am really very pleased and honored to invite my speakers for this session, Dr. Toni de Deu, who is Director of the Catalonian Agency for Health and Health Quality and Assessment, Miguel González Sancho, who is the Head of Health and Wellbeing Unit at DG Connect of the European Commission in Brussels, and Jill Littman, who is leading the Global Integrated Care Unit of Sanofi. I will be introducing them one by one before they speak, but I would like them to come on stage now. Please join me here. Before we start, I want to explain to you that since I know that some people have to leave earlier to catch their flights, we decided to have all the speeches one after one. If there are burning questions after each presentation, please let me know. But we will have, after the presentations, plenty of discussion time. So please bear with us. We had to change the setup a little bit. Good. Toni has an amazing educational background. He combines expertise and degrees from different fields: family medicine, health economics, health management, primary and community and doctoral programs, etc., to mention a few. And he has been working also in Scotland, being the Director of Research and Knowledge Exchange of the Digital Health Institute. So many of you have seen probably that George Crooks was announced to speak in this session, but he unfortunately got sick. He couldn't come. And we are very grateful to Toni, who was so spontaneous and joined us for this session. He agreed to present here. He will be presenting a little bit about Scotland, more about Catalonia, but we expect him to set the scene for integrated person-centered care and explain to us his understanding and initiatives in this domain. Toni, please.
Thank you very much, Vali. Thank you very much for trusting on me and replacing George Crooks. Unfortunately, he's ill, and as you can see, I'm not George Crooks. And I haven't gotten Scottish accent, despite I lived in Scotland for 3 years, and working in the same organization that George Crooks is the chief executive now. So it's a pleasure for me, this Scottish connection as well. But the topic here is about integrated care. And this is in honor to George Crooks. Is a slide that I suppose he would put in this presentation. So it's about we've got some challenges in the care delivery. Challenges that it's been told, aging society. You can see the pyramid that it's turned into such, not a pyramid, it's like a histogram of the European population. And we've got some challenges: chronic conditions, health work shortage, financial and sustainability, healthy life years versus life expectancy, and health inequalities. So this is to set up the scene. And because I'm going to talk about about integrated care, I think, and I'm not going to give you a definition of integrated care, I'm going just to put a conceptual framework that is one of the frameworks that I feel more comfortable to share with you. This conceptual framework was done by Pim Valentin from the Netherlands, and as you can see, and for the ones you know a little bit about integrated care, normally we talk about two axes. One is the vertical integration of integrated care, and the other one is horizontal integration. If we talk about vertical integration, we can talk about clinical integration. As you can see, is person-focused. Then we can move a little bit upper. Professional integration, that means different professionals getting together, contacting together. Then organizational integration, this is more a population-based orientation. And finally, the system integration. As you can see in the slides, there are two sides. One is the functional integration. Those are the things that help, enable that integration helps, but at the same time, there are normative integration issues. And the horizontal integration is the breadth of what we are thinking, if it's more person-focused or if it's more population-based. So what I'm going to talk, after setting this scene, I'm going to focus on different levels of organizations that they are talking about integrated care. I'll start talking about the perspective, the work that the WHO is doing on integrated care. Then I'm not going to talk a lot about what's doing the European Commission, because Miguel is going to talk about that, but I'm going to focus on at national and regional level. So WHO has been working and trying to develop a framework for action towards coordinated and integrated healthcare. They started years ago trying to develop a concept note. Then what they tried to do, they did a field work in many countries that I'm going to explain to you, to finally to give some policy suggestions and a change manual document for you to follow. The exercise the WHO Europe did, they started 9 researchers. They conducted key informant interviews. Maybe some of you have been interviewed. More than 12 languages were used. They went to 45 countries. What they produced is more than 90 different experiences strengthening health services delivery. And to put some examples to touch the floor, some of the examples are the development of implementation of an e-health system in Croatia, for example. Another example I could share with you is community intervention teams for acute discharge in Ireland. Another one is integrating health and social care in Finland, an Eastern Lithuanian cardiology program. As you can see, the experiences are very varied. But this brought some conclusions, and they work on the drivers for change, came out of all these exercises that they did, the field workers. So what can we do? We should know that the problem is measurable, well documented. Secondly, that it's technically feasible. Another thing that's important is the channels for change. It should be a gradual period of diffusing the idea. We cannot implement integrated care on spot. We need time. The example is what happened in Norway in some pilots. It took more than 10 years, and this is not only in Norway, it's happening all over the world. And then there is an important issue about communicating at different levels, and finally creating the conditions to be shared the knowledge of integrated care. As a result of this exercise, some common barriers were detected, and some barriers that has been taught during these days here. One is lack of leadership, and this is one of the key issues: lack of leadership, inadequate financing systems and incentives, limited focus on health in all policies, inefficient focus on primary care. This is a key issue when we talk in integrated care. Lack of an integrated information system. Information systems, I'm going to talk a little bit further on that. Workforce under pressure. Many of you in your regions, in your countries, you are suffering from this workforce pressure. We have to rethink the roles of the health and care professionals. Budget restrictions, I'm not going to insist on that. Insufficient investment in public-private partnerships. And partnerships is one of the key solutions for integrated care. Then insufficient investment in research. We need research as well. And services design from the provider perspective. This is what's been happening, not from the person perspective. So I want to give you two takeaway messages from the exercise that the WHO did. One of them is that there are minimum requirements for implementing integrated care. And there is the list here that you can see, but the minimum requirements are at the health system level, at other sectors. We must include other sectors. What we must include especially is the people, the person-centered approach. And this is the exercise that the WHO has done and is important for us to take back as a message, a key message, that we must define the people-centered health services delivery. As I said before, it could be health system is on one side and other sectors should be taken into account. Secondly, my second approach is what's the European Commission doing? And I'm very honored to having been taking part in the European Innovation Partnership on Active and Healthy Aging. This initiative started years ago, I think in 2013, if I'm not wrong, to start and introduce a new model of collaboration to facilitate innovation. So one of the key issues in European Innovation Partnership, maybe many of you have been involved, is the ownership of the stakeholders is the key issue. A high-level political commitment, there was there, a very large-scale deployment and innovation, awareness and best practice sharing across Europe. You'll see the numbers of best practices that flourished, combining demand and supply sides of innovation, and finally building on existing instruments and new ones. But the objective were very clear. One of them is triple win for Europe, is the health and quality life of the European citizens on one side. Secondly, sustainability of the care systems. And third is growth of the economic and industries in the European Union. And what came up with this initiative, and especially in the Integrated Care Action Group and the European Innovation Partnership, as you can see, there were many initiatives dealing and tackling integrated care. The purpose of what happened in the European Innovation Partnership is not just showing what you were doing, is sharing it and trying to compare and scale up what you are doing well in your region, in your local municipality, in your county, in your nation, to scale up to others. And then this is combined with the reference sites that maybe Miguel is going to talk about it. And then another exercise that's happening in the European Innovation Partnership is twinning, learning face-to-face from the best of the two parties. So the European Innovation Partnership, what we produced is we defined some dimensions of factors enabling successful integration of care and readiness for this integration. So in this image that you can see, there are a few of the dimensions that we defined. And now I'm going to be more concrete and giving to you some specific examples. I'm going firstly to Scotland. As I said at the very first slide in the integrated care background, I mentioned about there was a level of systemic integration. Scotland did that. So there were some enablers, like the national policy drivers, that like the public service reform, the public bodies joined working in Scotland, the Act passed by the Scottish Parliament in 2014, Reshaping Care and Older People program, and finally the Telehealth and Telecare Delivery Plan for Scotland. So those were enablers to start thinking about what can we do next. And that was at a very high level. As I said, it was something that was passed by the Scottish Parliament Parliament. And before the integration, Scotland had 32 local authorities and 14 NHS boards. And in terms of the integration, the aim was to create 32 new health and social partnerships, sharing some responsibilities. And some NHS boards and local authorities had remained having some competences in different issues. But the key issue is that these 32 new health and social care partnerships, that they are already in place. This is the time scale that they used in Scotland. So they started in from May to August 2014. There was a consultation process. Then regulations and guidance were completed. Then there was passed by the Scottish Parliament, and there was a duty of the 32 partnerships, health and social care partnerships, to define their strategy at the territory they were working on. So that's the key issue. And now the process is going on different stages in different health and social care partnerships. So this is an example of what's going on in Scotland, but what helped integration? Cross-party support, negotiations, discussions, agreements on one side, NHS support, but at the same time, the local authority support as well, and everybody agreed that they should include partners as stakeholders. That was a challenge, something that was needed, and they had a great vision of what they should be doing. Now I'm going to move to my native region, Catalonia. As you can see in the health plan of Catalonia, our approach was different. We started with lots of existing experiences, what we call pioneer territories, and then these pioneer territories brought the idea to the government to set up a strategy. So it's the other way around. So we took advantage of what was in place, and then we moved upscale. That was reflected in what's the health plan for Catalonia 2016-2020 as one of the main areas of priorities of the Catalan government. So, and this is combined with the person-centered approach of the Catalan plan, but at the same time, two main policies are key issues for the Catalan health plan. One is health in all policies, and the second one is person-centered care. To tackle this, health in all policies, my minister used to say in the government where all the ministers meet, so all of you are ministers of health. So this is one of the end results of what's happening, is an interministerial program for integrated care at different levels. So this is a great agreement, because integrated care is not just about health, it's about working together with other different sectors. So using the experience we had from the European Innovation Partnership, and as a result of an ongoing European project called Sirocco, we defined a methodology, a maturity assessment on how mature your integrated care model is. Each region did their exercise, and the results of that is that we could compare not just what's happening in terms of maturity in your own region, but at the same time, you were able to compare what happens at municipality level, at county level, and even at provider level. So this is an excellent tool, a self-assessment tool, to see at what level of maturity and the gaps you've got to improve in integrated care in the various dimensions that you can see in this diagram. So we used in Catalonia, but there are more than 30 other regions that they are using this model as well. In Catalonia, what are the key drivers? For one side, the chronic and integrated care policy-driven orientation. Secondly, introduction of a stratification. What we did is not integrated care for everybody. We started slow and stratifying the population to know who had more needs to be tackled in a program of integrated care. Then there was a big commitment. I said the leadership was important, bringing up clinical leadership from the bottom up, and then the shared ICT, shared information systems, I'm going to talk about that. Important, very important, how the information flows across the system, overcome financial barriers. That was done with introducing new joint cross-cutting targets between the different sectors. And finally, another priority was promoting more care at home. So this is the ICT readiness of Catalonia. We are able, and we've been able to implement integrated care because our ICT system is mature, is ready. So that's one of the enablers. The second one, what you've got, the risk certification tools. So this is something that's in place. Thirdly, talking about the person-centered approach, we've developed a platform that's called My Health. This is a platform that the citizens can have access to their information. But we started years ago. We started in 2009 as an informative platform. And now what we've produced, we've progressed into a service platform. So the citizens have something to interact with the platform. It goes from e-consultancy to upload apps for themselves. This is another tool for integrated care. And finally, the key issue. When we talk about integrated care, I'm not just talking about integrating health care. I'm talking about integrated care in the intersectoral approach. So one of the things is what we are working on in Catalonia is integrating health and social care. But we need a model to follow. The model, first you need a legal framework. Secondly, you need the information sharing model. We need infrastructure, and that's what we are working. And this is my last slide, and this is a pilot that we are carrying out in Barcelona city. It's not a small city, it's not a small pilot, more than 2 million citizens. They are being piloted how to bring together the information from the health system to the social care system. So this is already in place. So there is negotiation with what information should be shared between the two different care levels. So we started with Barcelona. That was a challenge because if Barcelona fails, the rest will fail. We didn't start with the small pilots because maybe they would be difficult to scale up. So we did the other way around. We started with the biggest city in Catalonia to see if this was feasible. So this is about what I wanted to share with you, and I'm glad to respond to your questions afterwards. Thank you very much.
Thank you very much, Tony, for this very comprehensive overview. Our next speaker is Jill Littman. Now that we learned about the policy maker view from the regional perspective, we would like to know what industry, in particular pharma industry, can do for integrated care and is doing already. Jill is leading the Sanofi's global integrated care team within the diabetes and cardiovascular global business unit. He has had several operational, business, managerial positions over the last 17 years even. And in both mature markets, but also in emerging markets. So this is particularly interesting as well. And he has been working also on devices. That's another interesting point. Jill.
Thank you. Thank you very much. Good morning, everyone. Very happy to be here in the beautiful city of Tallinn, which I discovered yesterday. Very happy also to be surrounded by two Spanish colleagues. Have a particular tie to Spain. So first of all, thank you very much, Tony, for your very interesting and insightful presentation. There are many things I share with what you said. Some of the things I take away. One is we need a vision. And if I were to describe integrated care in a very simple manner, it's basically about making life and health of people better. I think that's the vision, and I will try to give you a very concrete example with diabetes, which I'm working on. Second, it's about people, and often in the pharma industry we talk about patients, and I'm trying to advocate internally to my company, to Sanofi, for shifting towards people, because at least as far as diabetes is concerned, it's about your life. It's not only about your health. No one likes to be called the patient, and I think if we shift the way we look at things this way, we have a better chance to succeed. And third, it's about leadership. I absolutely agree with that, and that's why we are here, and I would also like to call for action at the European level, because I have a global role. I see other regions, especially the US, moving very fast, and I think Europe needs to accelerate, and we have many reasons to believe in ourselves, so we should do it. Let me start with a quick introduction on diabetes. So you may know or not that more than 400 million people suffer from diabetes today, and usually they suffer from diabetes and comorbidities. It doesn't go alone. You have cardiovascular problem, you can have complication, nephropathy, retinopathy. But as importantly, the disease is expected to expand to more than 640 million by 2040. So just if you look at this figure as a starting point, it is a huge burden on any healthcare system in the world, and it will just get worse. Second, we as a pharma industry, and Sanofi in particular, I think we have brought a lot with the drugs and the innovation we have put on the market thanks to our R&D efforts, and I think we can be proud of it, but still, in spite of all those new drugs that come from us or others, 1% out of 2 is not reaching his or her glycemic targets. And those figures are actually far worse in emerging markets. I personally lived in Mexico. This is a major disease in Mexico and in many parts of the world. So the situation is far from being satisfactory, and the management of diabetes in the world is not at all optimal. Why? Because living with diabetes is complicated. That's maybe as simple as that. When I talk to patients, it's very interesting that the first thing they ask from us is, how can you help us to have a normal life? How can you help us to live a life without this burden of diabetes? Because living with diabetes is a 24/7 job. You have to monitor your glucose regularly, up to sometimes 6, 7, 10 times a day. You have to prick your finger, so it's painful. You have to monitor what you eat. You have to monitor your physical exercise. You have to, when you are using insulin, you have to adjust your dose. So it's something sometimes quite complex. You have to manage your comorbidities and deal often with many healthcare professionals, different ones. And also something we rarely talk about is all the, of course, emotional part that go with it. Feeling of loneliness, frustration, the fact that you live with this permanent burden on your shoulder is difficult. So that's complicated to live with diabetes, and I think everyone has a different way to react to it. Second, there is a lack of healthcare professionals. We have specialists, of course, but not enough. And when you look at the figure I just showed before, it's not going to improve because the population is going to grow much faster than the specialists able to tackle with it. And the general practitioners have a lot to do. And of course, it's very hard for them to follow all that is new in the field of diabetes because there are many drugs, many treatment pathways, and that's also complicated for them. So there is an urgency to act because, of course, the consequence of all I'm talking about is that it has unsustainable cost for the society. The cost of managing diabetes, but also complication, hospitalization, is absolutely huge on the healthcare system. And if you consider the increasing prevalence that I just mentioned, it's just not sustainable for any system in the world. So there is an urgency to act. The good news, I think, and that's why I'm here as well, is that I very much, and we very much believe in digital health. So we can call it integrated care, digital health, connected health, but it's obvious that the technology and the digital age are bringing new hope to try to find solutions to this problem. And I would like to be very concrete on the examples I gave just before. So, of course, we are bringing drugs and we continue to bring drugs to patients. When it's about monitoring your glucose, we now see the emergence of so-called continuous glucose monitoring, where you don't need to prick your finger anymore. You just have a device that is on your arm, for example, and I tested it myself. And that removes this burden of having to prick your finger. But more importantly, you have a continuous measure of your glucose, so it's more reliable than, I would say, several points of measuring during the day. Some of them send alerts, so you can be alerted. And also, very interestingly, the usage you can do out of it is you become in control of your own disease because you scan your device and you can see the impact of what you have eaten, for example, on your glycemia. And this has much value because as much as you become in charge of managing your disease, you learn, you get better at dealing with it, and that is very much of a value for someone. I was talking about the challenges around insulin. There are two. One is you have to adjust your dose as your disease evolves, and usually you have to go back to see your physician to do that. And we know that it can take months to have an appointment. You have little time. There are now new solutions that enable to do that on a remote basis, what we call decision support solution. They can be digital, they can be physical, and very simply the physician is putting some parameters so that depending on some data, the dose recommended is changed. So that is a gain of time for the physician, for you, and you can also become more and more independent on that front. The second one is we also know that, like in many diseases, there is an issue around adherence, like how much you adhere to your treatment. And if tomorrow we are able to track adherence with, for example, connected insulin delivery pens, we can have a better understanding of how the person is dealing with diabetes. Nutrition, I've seen some very interesting startups now proposing very sophisticated but also simple to use solutions whereby you just, in a very simple manner, record your meals and based on the literature, on a number of advice and in relation to your glucose levels, you are given very simple advice on how to, what are the best meals, what are the worst meals, what could you do to better adjust your nutrition to your needs. And last concrete example, I was talking about emotions. What we see very much working in the space of diabetes is social communities of patients, peer-to-peer support, because it's very good to receive advice from your family, from your physician, but I think there is nothing so valuable as getting insight from people who share the same difficulties than you do, and the use of digital, of social communities is assessed as extremely impactful for people. So as you can see, there is a lot coming, and one of the key questions is how we integrate it all. Besides the impact for patients, of course it's interesting for healthcare professionals because they can have a better understanding of the adherence of their patient, the way they deal with their glycemia, how it's evolving across time, and they can improve their diagnosis. And it's also interesting for healthcare systems because we can reduce the cost if we, for example, reduce hospitalizations. And last, I think there is also an interest for industry like ours because this is new business opportunities and even, to be honest, I think potentially new jobs. For example, I see the emergence of new coaches that can work on a remote basis to support patients with a number of data. And I think if it continues to evolve, we could imagine new jobs being created on that space. So I think there is a hope, but we have to be realistic, and you showed that very well, Tony. It will only happen in certain conditions. One, it has to be integrated. It's good to have different pieces, but the real value is in the integration, which is why both Tony and I, we are talking about integrated care. And that's not so easy to do because it's involving lots of stakeholders, people or patients, healthcare professionals, pharmacists, general practitioners, specialists, hospitals, but also industry players, IT companies, governments, etc., etc. So this integration is a challenge, but if we are able to do it, I think we will maximize the impact. Second, I think we also shouldn't be too naive in that there are many tools that are being developed, but not as many that are being really used by people. And you can ask yourself, what do I use on my iPhone? So I think we have to really put the users at the center. And I think many of the things I see developed will not survive because not all will be adopted. So how do we ensure real adoption, how do we make sure people use it and we don't just develop something nice, is another challenge. There is a need for trust in the data, trust in the way it will be used and by who, and for that regulators have a key role to play. And last, I think there is a need to work all together. And when I say all together, I also mean between the public and private sectors, because I can tell you that in the US this is happening much more, and we have to overcome those sometimes barriers that we have in working together, because everyone has something different to bring. We as industry, regulators, civil society, patient, and only if we are able to work all together we will really make it happen. We are very active in my company on that front. I'm very proud to lead a team which is called Integrated Care, which shows that we consider that being in healthcare is not just about bringing drugs, it's about trying to improve life of people with diabetes. So we go beyond. And how do we go beyond? We are developing a number of services and solutions around our drugs. So for example, patient support programs. We also are developing solutions like what we call titration, these tools to help people to dose their insulins. We are also working on connected pens for injection of insulin. And also, besides those activities, we have formed a joint venture with Google to try to combine the power of Google in data, in analytics, and in miniaturization with our knowledge of diabetes to create something really new. And this is a separate entity, because I think it has to be also a different approach to diabetes, based in Boston, starting in the US, but meant to expand, hopefully, in Europe. So as you can see, we are very active because we believe this is the future of healthcare. And last, and this is where I'd like to finish, I believe this is a fundamental stake for Europe. So one personal comment, my family comes from Poland. I was born in Strasbourg, where the Commission, the European Council sits. It has been under German and French influences, and my wife is Spanish. So I have a very deep European identity. I'm very, very attached to Europe. And I can tell you, because I have a global role, that for now, Europe is lagging behind. We are lagging behind the US. It goes faster there. Companies are developing faster. And I do not really accept it. I want that to change. I think we have reasons to believe in ourselves. First of all, there is a new leaders generation at the political level. In Estonia, we have a common point with France, where there is a president aged 39. In Austria now, there's going to be a chancellor aged even 31. So a new generation is coming. Second, I know that digital health is at the top of the agenda of the European Union. And we will talk about it in a second with my successor on stage. So that's good. There will be a declaration. I know that the Commission is working on a roadmap. There's going to be also something done at the level of the Ministries of Health of the European Union. So that's good. I think we have a very strong academic network in Europe, very strong healthcare structures according to our values as Europeans. And also, I think we are very good in entrepreneurship. The problem is often when, at least in France, when entrepreneurs succeed, they go to the US. And this is something I'd like to see changing for us. I believe that digital health can be really supported by Europe, but I also believe that digital health can support and help Europe, because it could be part of our European project to become one of the best regions in the world around healthcare and around digital health. So I hope that's going to happen. We are very committed to contributing to it, and I would like to thank you for the opportunity to talk here. Thank you.
Thank you very much, Jill, for this passionate presentation. And Miguel will be telling us how the European Commission is supporting all of this to happen and supporting digital health for a very long time now with numerous initiatives. As I said, Miguel is the head of unit Health and Wellbeing at DigiConnect. Before that, he has had positions in the unit ICT for Inclusion, head of unit for administration, deputy head of unit for policy coordination, and a few other positions as well, and he holds an impressive number of degrees of law, international relations, business administration, European policies, financing management, and auditing. Miguel, please.
Thanks, Veli. Well, first of all, thanks to the audience for being so numerous. We were a bit concerned before. The room is very big. How is this going to be filled? And there's quite a lot of people who are still here with us. Thanks for that. Thanks to the organizers, to the Estonian hosts for a very, very nice conference. And then I will start my presentation, and I must say that it follows up very well with what Gilles said to end his presentation. So I work for the European Commission, a service which is called DG Connect, which stands for Networks, Contents and Services. There's actually several services from the Commission, several directors general that work on matters around health and care and the digital, let's say, tools. Gilles mentioned it, and also Veli now. It is true that I see that this digital health and care topic has risen in importance in the political agenda at European level and at national and local level, and both are of course linked. So in terms of European policies, as I said, we are several people who are working on those. Those working on the digital side of things, let's say, I belong to that category, but of course mainstream health policy and other policies too. For instance, data protection policy is something which is very much talked about in relation to digital health and care these days. I suppose that what I would like to talk about today is the case for European intervention in this area of digital health and care. I always summarize saying that there's two main grounds for such interventions, such coordinated action at the European level. The first would be to set the right enabling conditions, and the second would be to pool efforts and support efforts from across Europe. So I would like to develop a bit on that case for European action and on specific instruments. Okay, I'm not going to go much into that. I will, well, this is the digital single market. It provides the strategy for the digital economy and society. And the recent development has been to include a chapter on the digital health and care as part of this strategy. And from the side of mainstream health policy, this aspect of digital health and care is also gaining importance. So it's difficult to read the slide, but I will mention very briefly that when the Commission decided to have this chapter on digital health and care, there was some polls, some surveys being done, and basically the picture that comes up is that there's a lot of the potential for digital, let's say, products and services in the area of health is unfulfilled. There's much more that can be done, and there's several indicators for that, like it is mentioned there, the access that citizens have to the electronic health records, the usage by doctors, health professionals to some of these solutions, etc. So much more potential is still to tap, and at the same time, a lot of willingness for people citizens to share their data for certain purposes, like research or their own treatment. So, I mean, you have the potential and then the willingness to go further. That's a bit of a context. Just to recap, Commissioner for Health and Food Safety, Andrew Kaitis, was here yesterday saying that we are about to prepare a specific policy proposal in this area of digital health and care. Basically, as Veli said, from the Commission, we've been working on this for many years, so it won't be fundamentally a revolution. It will be very much revisiting the approach, and this is what I will develop today. Very difficult to read, but I use this still as a background. This is just a copy from an official, from a communication, official text from the Commission. Let me just recap what are the 3 priorities that were identified there and that we will elaborate upon in the upcoming policy proposal that will come. These policy priorities they are all related, and they revolve very much about data, access to data and management of data, like many things these days in the digital world. So the first priority is secure access and exchange of data. So for the citizens to have access to the data, to be in control, and for the possibility to exchange those data securely. Number 2 is very much about treating those data through appropriate data analytics, data infrastructure, like high performance computing, what have you, in order to deliver personalized medicine. And number 3, it's about integrated care, which is the topic of this session, and integrated care with the person at the center, I would say, which is also in the title of the session, so that patients, citizens, they can provide feedback, they can receive feedback, they're empowered. And coupled with that, which is the demand side, I would say, of care, there's also important, from a European perspective, the supply side, so that there can be an innovation ecosystem and a market in Europe where solutions, products and services can, let's say, travel across and overcome the fragmentation that exists in this area. So I mentioned the priorities, and I would like to talk about instruments, which is perhaps the main focus that I've decided for my presentation of today. Instruments at European level, because I think this session is very much about implementation and practical progress. I said it before, I think the added value of European coordinated action is very much on setting the enabling conditions, first of all. And what is that referring to? Well, first of all, of course, legislation, law that exists, because we often hear, health care, this is something for the member states, this is, or for the regional, depending level, this is where the competence is, legal competence, which is true to a large extent, but there's a lot of relevant rules, let's say, at European level. I've mentioned data protection, clinical trials, but there are other many things, even, public service information could be potentially relevant. And so it's important to have, let's say, enabling rules that allow, developments on the ground. It's more than that to it. I mean, it comes to my mind, it's not just things like the privacy. There's even a debate about fundamental rights that has emerged recently in relation to this aspect. There were scandals recently in 3 countries, not to mention them in the UK, in Italy, and Belgium, about healthcare entities selling data from patients without having properly followed the protocols, as it were. So of course, there's concerns about, if insurers could get hold of certain data. So, I mean, this is touching upon, as I say, from the legal perspective, even on matters around fundamental rights. So it's quite important to have a common book here, I would say, so that citizens are not less exposed or more exposed according to the country where they live. Also, in this space of rules, let's say, it's important to address the issue for interoperability and standards, certification, and all of that. That's something important. So enabling rules of the game, as it were. It's also, so it's the middle of my slide, there, legal implementation and coordination. The funding, okay, support the efforts. There are many efforts, and of course, it's part of a mission of the European level, let's say, institutions, the Commission, to top up, if you like, to stimulate, first of all, cooperation amongst people, and then put a little money on top for them to go further. I'm talking about research and innovation, of course, H2020, the active assisted living program, which is supported by the EIT health efforts. Of course, research and innovation, but also deployment, connecting bureau facility, support for for exchange of patient summaries and electronic prescriptions for those who know it, structured funds, etc. Something important for where I come, where I work, it is the tools, the capacities for processing data and for sharing this capacity to process the data and to analyze them and to come up with solutions. I'm referring to high performance computing, cloud, artificial intelligence. This is something in which the Commission is very much involved with support for research and development from the technology side. Let's say there's big budgets there allocated, and more the question comes up about health as a use case, because it's acknowledged that health is a very health and care. It would be it's a very data intensive area, of course. And there's these big promises of personalized medicine, of all these things that are possible, but it's not so simple. It's also simple because you need to have the data for starters, and then it doesn't flow so easily. So I think for a number of us who are working on this area, it is acknowledged that capacities, as I say, for the cloud, high performance computing, what have you, they need to be put in common and perhaps supplemented. But it is quite important to work on the case of aggregating demand, for this health data, and around cases that have citizen, let's say, clear policy impact. I give examples of what I mean by aggregating demand for health. Data to be processed through the digital, let's say, tools. Of course, we're talking about research, personalized medicine, rare diseases. The rare diseases is a very good case. I always use it. I mean, there's a bit of cases here in this country and another country. Of course, you want to put these things together in order to come up with solutions, but there might be others. So pulling all this data to come with research that provide solutions for patients, but I think also data for simply for administrative efficiency. I would say you can gain a lot. It's acknowledged that in health and care there's a big potential almost everywhere for doing better, being more efficient, and also the data for around patient empowerment and prevention. All this data around monitoring. Basically preventing people from staying in hospital for too long. This is very much the subject of integrated care we're discussing today. So number one, I mentioned the legal conditions, enabling conditions. The number two is the funding. And a very important instrument from our perspective is the soft policy, let's say, in terms of aligning and pooling efforts from the many actors that are on the ground, and including many of you here in this room. So everything around cooperation mechanisms and things have been touched upon, and Tony has introduced that very well. That has a lot of value. And this is also European cooperation. I mean, the people who are doing things to put them together. So I refer, when it comes to member states, of course, to the health network, for instance, but to the EIP, European Innovation Partnership on Active and Healthy Aging, that Tony has spoken about. But also other forms of cooperation which go beyond these countries or these regions, cooperating. Like I think of the European reference networks for those that know them, where the idea is to really put in direct connection health professionals and patients to find solutions to specific problems. I'm very interested in this area of citizen cooperatives and platforms for data sharing, which is a sort of alternative model to the state or authority-driven approach. So there are many things that are bubbling under here, which are very interesting in terms of cooperation. So just to sum up, and I'm in the red already in terms of timing. So it's enabling conditions, legislation, funding, and stimulating this cooperation. That's something where I see the added value from cooperation at the European level. This slide, I won't go into it. It captures a bit some of the things that I mentioned before. It's not complete, but it summarizes, especially let's say there is the funding part, And the cooperation part, so there are things mentioned like H2020, AAL, EIP. It's a bit, it captures, but it's not complete because the legislation is not mentioned there. But I still wanted to show. Another slide, impossible to see, but the slides will be available, is the European Innovation Partnership. I like we call it the EIP house. It summarizes a bit what is let's say the approach which is followed here. Of course, I won't go into the small print, but I think I would like to stress the elements. So the EIP, many of you know, but basically it's about structuring this cooperation between ecosystems across Europe, very much regional ecosystems. And what we are trying to do there for a number of years, the elements are basically to have a vision with a strategic plan, and which has been recently with the blueprint, we call it the blueprint, has been kind of revisited. And now with this policy initiative that will come up, we will further revisit. The core elements of the structure of the functioning of the EIP are two, which is the reference sites, the so-called reference sites, and other partners who are not reference sites, which is the kind of geographical approach, I would say. So you take an ecosystem and you try and have an integrated approach. And of course, the action groups, which is more thematic, so focusing on medicine adherence or falls or what have you. The aspect of measurement of impact and comparing the impact is quite important. In the framework of the EIP, there is some framework which is proposed for that, but there are others as well. The aspect around markets, innovation to market, it's quite important and very, very difficult in this area. So you have the healthcare systems, but then you have many solution providers, and then how you match the two. And then at the bottom, but impossible to read, but there's a timeline with the next steps in this process of redefining the EIP. So yeah, I need to conclude. I will say that this was mentioned by the commissioner yesterday. There was a public consultation that was recently concluded. Some of you I know participated. Thank you very much. It was a very good participation, almost 1,500 responses, which is very good for a commission driven, launched public consultation. And okay, I don't have the time to go into the detail, but basically people were identified there. What are the main concerns in this space to further promote digital health and care? And you wouldn't be surprised: privacy, cybersecurity, non-interoperability of electronic health records, and then with some suggestions for further action at European level. I would like to leave it at that. I won't go into the slides. My final message, that's information for you to see, but basically as a very small commercial to just say, for those interested in the H2020 work program, in particular in the area of technologies for health and care, the next work program, so offering opportunities for submitting proposals, has been just pre-published this week. So some of you might be interested to have a look at it. And there's a number of other milestones, events that are coming up. I draw the attention to the Conference of Partners of the EIP that will take place in February next year. That was it. As a final message, I would say that from my side, I do see that, of course, implementation of these digital solutions for person-centered and integrated care is something that happens very much at the local level, and it has to be like that. But at the same time, it is true that the solutions can be common very often, or exchangeable at least. And by solution, and the European dimension is very important for that. And by solutions, well, I mean everything. I mean the rules, have some commonality of the rules I mentioned, products and services, but even the providers that they can travel across Europe, researchers, doctors, etc., and exchanging experiences. Sorry for taking a bit longer, and thank you very much for listening.
Thank you very much, Miguel, for this comprehensive overview of activities. Before I open the floor for discussion, please be aware that the organizers have extended the duration of this session by at least 10 minutes because we don't have to perform the session transition, what they call it, because we will stay in this room for the closing keynote. Please stay longer if you can. The blueprint mentioned by Miguel, I would just like to tell you that I have the pleasure to support the Commission within the so-called V4H support action in further developing this blueprint and updating it and advancing it. So please let me know if you want to contribute. Let me know that later after this session. Now, we did not have the chance to involve also users that will have to adopt all these nice solutions and policies and strategies. So I would particularly welcome questions and statements from the user perspective, but also from the ICT perspective. ICT industry was also not involved in this. So please, questions. Yeah, Mario?
Microphone.
Okay, hello. Let me introduce myself. My name is Mario Ravic. I'm heading IoT and Digital Health Unit in Ericsson Nikola Tesla in Croatia. And I'm, as an industry player, I'm for a very long time involved in digital health, also on global level, and participated in some European projects like CareWell and part of action groups. So pretty familiar with the situation on the table. Two questions. One for Mr. Dudu. I'm really interested in digital interaction between patients and providers. On my health platform, what were the most successful services that lifted up that interaction for integrated care? And the question for Mr. Littman, you know, as an industry player, if you were to roll out diabetes management program in the States or in Europe on pan-European level in 3 or 4 years, what would be the outcomes? So from your industry to roll it out, to make it a successful rollout in Europe and in the States, and I'm really interested for the public to find out that from the industry perspective, what are the barriers and what we are struggling with. Thank you.
Okay, thank you very much.
So I start with the first question. Maybe some of my colleagues have explained during these days how the platform My Health in Catalonia is. One of the things that is new for at least in our region is the capacity of the platform to admit apps that they are produced by third parties. And another thing that we've done in Catalonia is an accreditation system for apps to be uploaded to the platform. This is under the guarantee of the Ministry of Health, Catalonia, that the apps are certified. So everything that's uploaded in the app, in the platform, can be automatically, it's been shared in the electronic health record. So including the health data that the apps collect. And one of the things is the collaboration with the private sector. And this is one of the key issues. We are open, and there are examples in the My Health, the platform, of collaboration with the private sector. So we are already working with private sector. And then maybe you could ask, what about the information that comes from apps and the information that comes from other systems, more accurate and what the professionals want to introduce data about the patients, some test results and things like that. What the professionals see in the health record is two different visions. What comes from apps, so even in different colors, and what is produced by the healthcare providers. So you can compare. And then the next step will be, can we trust the results that come from apps? And this is the next step.
Thank you. Jill?
Yeah, so if I understood well the question, and if not, please let me know. What would be the outcome if we were to implement diabetes management in the US or in Europe? So first of all, of course, it would be around health outcomes. The one which is often used in diabetes is what we call A1C, so the average of glycemia over the past month. And what is very interesting is that we see now digital solution demonstrating an impact on that metric, which is sometimes comparable to a drug. So the question is if we were to combine drugs and those solutions together, do we improve the outcomes versus the drug only? Is it the sum of both? Is one question. The second one is which outcomes? Because I think that the arrival of new solutions also open the question of the outcomes we want to have. For example, another one which is starting to emerge is what we call time in range. It's not only your average glycemia over the past month, but also how long do you stay in the target range, which is as important. And I was talking about the continuous glucose monitoring. This is something that we are now much more able to measure. And we have drugs that have this impact. So how will outcome evolve is one question, and this is something we are working on. And of course, the other part of your answer of your question is beyond health outcome for patients and HCPs, the cost part, because the big bet is that we can also lower cost, and I know that may sound a bit strange from the pharma industry, but I tell you this is at the heart of our concern, because of course right now we are engaged in a discussion with payers whereby we are heavily challenged on prices, and the move I think is, can the combination of drugs, devices, services and data improve outcomes and reduce cost if, for example, we are able to reduce hospitalization or complication. The challenge is the time frame, because often you have a short-term cost, and I'm sure you know that, but the savings you may have to wait a bit, and it's neither in the political agenda nor on the payers one sometimes. So how do we reconcile, but health outcome and cost?
Thank you very much. Other questions?
Excuse me, we have to finish. Our president is arriving in a second. We'll try to function 7 minutes into the next session.
Okay, that was executive, an executive order.
Right. But we still have time for one question. Yes, please.
Thank you. My name is Silas Olsson from Sweden. I have a question for Tony. Your experience with integrated care solutions in both in Scotland and in Catalonia, have you seen some results of that yet in terms of, for instance, moving the patients from more specialized care to primary care and to home care? Yeah. Maybe this is too early yet, but this is my question. And then I have a question for Miguel. And this is about the public consultation closed a couple of days ago, which you presented here. What's your plan to do with the input from the public consultation? Will there be some formal talks with the member states, or how are you going to proceed with that? Thank you.
Thank you very much. I'm afraid the answers will have to be short.
Short, okay. So I think, thank you for the question. It's very appropriate, especially with the position I am, because I'm the director of a health technology and evaluation agency of Catalonia. So what we do is we monitor all these, the outcomes, health outcomes, and we are working on the evaluating the impact of the implementation of integrated care in the health system in various, there are a set of indicators. We started with more than 150 indicators, and we're trying to trigger them because there were too many, and we are working on that, and next year we are going to have the results of the in various pilots that they are working on integrated care, so we'll have tangible results.
Thank you.
Okay, very quickly. So, Silas, thanks for the question. The results from public consultation, first of all, we will report about it. The Commission always does that officially in November, for full transparency. And then what we will do with that, first of all, the main purpose is to gather input for the policy proposal that is in preparation. Then, with member states, we will use this input indeed to take the discussion further with them about future actions, but not only with member states, with relevant actors, like with the EIP, for instance, that I mentioned. Also, we will take the results to see what are the main concerns and requests that those who have responded have, because it was a quite significant response. So we will use it. It's very useful for us.
Okay, thank you very much. And I would like to invite you to send to me, I'm Veli Strootman, the moderator. You see my picture there. Please send me questions. I will make sure I share those with our speakers after the conference, and we'll try to provide you with answers. Please join me in thanking our speakers.
Here, our president has arrived. She will be here shortly. She will be giving the final speech, and then we have some final remarks and the lunch. That's our final session here at the eHealth conference. So please be seated, and we start shortly. And this is our final session, and I'm very delighted to introduce here the President of the Republic of Estonia, Ms. Kersti Kaljulaid, for final remarks. Madam President, please.
Ladies and gentlemen and distinguished participants of the concluding session of the eHealth conference, as you notice, we Estonians, we do everything differently. Presidents normally come for opening remarks, we choose the other way around. But I sincerely congratulate you for these 3 days of wise discussions, inspiring exhibition and fruitful meetings about health in the digital society. It is of utmost importance to understand what digital society can offer to improve the well-being of our people in Europe and, of course, beyond European borders. Indeed, one may ask, what will change now after this conference in the life of a, let's take, 60-year-old lady in Tartu, southern Estonia, or somebody else, let's say a 53-year-old man in Rouen, France. Perhaps what they both expect from life is to enjoy it happily, enjoy it healthily, and as WHO has phrased it in preamble to its constitution 71 years ago already, people do expect the physical, mental, and social well-being. And you know, analog or digital, it doesn't matter. It is no different in digital society. Human dignity comes before digital. Countries with robust welfare systems have experienced dramatic improvement in the life expectancy of their citizens, more than 12 years from the times where our constitution was signed. True, today we cannot attribute the rise to the advances in ICT in the health sector. Rather, the growth of life expectancy is due to the overall advances in medicine and rise of living standard. Problem, though, is that all these technologies and all this development has made healthcare extremely expensive. And digital will have a potential to improve our lives, as in almost all other domains, also in healthcare, but do it efficiently and effectively. Finally, we could also hope to see some savings in the sector. Nowadays, it's quite normal that we keep in touch with our loved ones via free video calls, create teams and businesses, and even vote in elections via internet, as many Estonians, by the way, did last week. We have also seen services and products, such as choice of next book to read or clothes to buy, which are tailored better to our individual needs and preferences. We can easily find our way in totally unknown country, and we can predict our arrival time wherever we want to go with the accuracy of minutes. We even know where the traffic jams are. We can very smoothly communicate with our governments and banks without leaving our home. At least some people can in Europe. In principle, we can reach all human wisdom in seconds from our mobile phone. It is essential to expect that all these modern conveniences and obvious benefits of the ICT should also be present in our health systems. And therefore, I hope that this conference has already had a real impact, and it will improve the well-being of people by digital means, as we have already experienced in all other spheres of life. Technologies can enhance accessibility, and it is especially important for those people who live in rural areas. They face the heaviest burden to pay a visit to a doctor. Also, those people who are poorer or with heavy domestic burden, they may find it very hard or troublesome to displace themselves. A nudge by an online doctor might be exactly what is needed to encourage them to make the effort before it will be too late. What can we do in Europe together to make this reality? You know, 3 weeks ago at the Digital Summit in Tallinn, the heads of states and governments of EU member states, they agreed here that we must embrace technology and reap the benefits. At the following ministerial e-government conference on October 6th, the Tallinn Declaration was signed to reinvigorate Europe's efforts to advance digital single market. This step marked a new political commitment at EU level on significant priorities towards ensuring high-quality, user-centric digital public services for citizens and also seamless cross-border public services for businesses. Our citizens, our societies, they need it because they anyway communicate and transact in technological world. It's just the governments who are the missing link nowadays. Governments, with them unfortunately also health services. They are mostly publicly provided in our Europe, which is a nice thing, by the way. The scope of the European Digital Single Market Strategy contains a direct reference to health. To fully unlock the data economy, the EU must also harness such assets to maximize the digitization of the European service sectors, in particular health and healthcare, energy, transport, finance. Now it is time to act for all health sector counterparts. We do get too often into debates about the competencies of member states or the Commission when we should instead focus simply on how to deliver to our citizens in pragmatic collaboration of states, Commission, but also private and non-governmental sector, each within their mandate and capacity, and people need not know who is currently acting to their benefit. I am truly proud and happy for the Digital Health Society Declaration that was yesterday open for signing by all interested participants. And I know that more than 100 organizations have already contributed to it so far. This gives me hope that we can collaborate in Europe in the most complex matters because our people want it. The EU e-health action plan from 12 to 20 defines 4 action areas for Europe. First, supporting research, development, innovation. Second, promoting international cooperation. Third, achieving wider interoperability of e-health services. And fourth, ensuring wider deployment and facilitating uptake. The Estonian presidency of the Council of the European Union has suggested that for making advances in all these directions, we should agree concretely that the aim in the field of e-health is to support innovation in healthcare using digital technologies and digital data. Only very clear definition of priorities can lead to better prediction, prevention, faster diagnosing, and more precise and personalized treatment. This approach supports the triple win goals of European health and digital policies, obviously. Increased access and safety in healthcare can be achieved through empowered citizens. And the real change comes through people using the tools online to manage their own health and to take an active role in the process of healthcare services provision. Sustainability of health systems will be supported by a value-based approach. Digital solutions can contribute to more efficient use of resources, obviously. And these resources can be better targeted, more integrated, and will lead to also safer care. New economic opportunities, jobs, and investments, they will also be created using data-driven healthcare innovation. The combination of large data sets from different data sources, this will enable the creation of new knowledge to prevent diseases and to improve the treatment methods, while also boosting the development and implementation of innovative database technological solutions. I have every reason to believe that in December, the EU health ministers will adopt in their council conclusions a clear and strong political commitment for action in the domain of e-health for the support of our citizens and our societies across Europe. Now, as the president of a digital society, I can say that we have succeeded to build up in Estonia a society which trusts technology. And I would like to share with you some thoughts and lessons we have learned as a society based on our own experiences, because technology is gadgets. The change, the disruption is in society, nothing to do with gadgets, only people. Security, privacy, and trust, they are of utmost importance. In health, more so than in any other domain, as we know. Benefits of the digital society would not be possible if people did not trust into their digital environment. They have to be sure that their data does not get lost, stolen, or manipulated. I can tell you from my experience in Estonia, but also from what I have learned listening to other people all over the globe, digital solutions by themselves are not a trust-creating tool. Some hope they are, but in fact they are not. What they can do is they can help to maintain, encourage, and broaden that if governments use it wisely. But trust has to come from transparency and from the government's will to build this trust, to generate this trust. Estonian society has only fully become digital with the support of its government, engaging closely with civil and private sectors, gradually building this trust. This engagement has balanced effectively the freedom and flexibility of the opportunities which are offered by digital solutions. And especially from the government side, ensuring privacy and cybersecurity as the prerequisite for building our e-government and public ICT infrastructure. To be more specific, our government supports our digital society in 4 elements, and every single one of them is equally important. First, we have a legal base to make transactions in analog world and in digital world legal equal. Wherever they happen, they're legal equal. We have digital identification for safe exchange of information on universal platform. We have e-government services which are using the same universal platform as our businesses are using. And we have possibility to create private digital services through the same platform as the government does. Trust, of course, does not arise immediately. You cannot have a law which would create trust. You need to build it gradually, starting from services people perceive less risky and going to the higher level services like healthcare, where people think risks are generally high. And it needs commitment and it needs patience. Guaranteeing and safeguarding the trust already built is also not an easy task. It requires constant investment, it requires constant time, effort, and commitment from all political parties. We know there are risks in technology, and we acknowledge them. But there are also always advancements that help us to counteract these risks. Risks are publicly broadcasted, not hidden from people, and what is taken, the measures taken, they are also well known to our people. We continue every day to face cyber incidents, in principle. I don't want to hide that at all. And we deal every day, like everybody who has a digital system, at some level with cyber criminals. But all this experience has simply shown us how to mitigate these risks and these threats. We can say that Estonian cybersecurity know-how and arrangements are really battle-tested. But not only cybersecurity, cyber hygiene as well. Our people know to protect themselves. We globally faced a test, all of us. It's called WannaCry. It was a virus, in fact. But you know, all over the world, lots of medical systems were also attacked by WannaCry. And the only reason they were was because they were simply not updated. Updated systems were not under risk. You had not a single WannaCry attack in Estonia. People who have already lived for almost a generation in digital world, they have learned cyber hygiene. And you know, it must be simpler to teach people cyber hygiene than it was when we simply tried to teach our populations normal hygiene, to wash hands, you know, and use toilets. Because communication means nowadays, well, you have to agree, they are much, much better. So it may sound like a huge task and difficult to undertake, but we can encourage other countries. We have done it. Our people are cyber hygienic, not 100%. Everywhere there are people who don't wash their hands, but they are more cyber hygienic. And this comes from experience, from starting to use these services gradually, from learning the hard way that if you are not hygienic, then you get a disease. This is a long way to go, but this needs to be undertaken to build this trust and to tell people honestly, technology will never care for you. It will always be the brain, the human person, who needs to guarantee cyber hygiene. But the good thing is that in Europe, according to recent Eurobarometer study, 52% of European citizens, they want access to their health data, and 70% are willing to share their data with others, including 63% at least with their doctor. Importantly, 23% are not willing to share their health data. Perhaps they still lack the trust. But as I described before, this is totally natural that people embrace change at different speed, and this should be allowed. It is the responsibility of the governments and all other stakeholders to work steadily towards delivering to those that are already impatient of getting the digital solutions to improve their experience with health systems, and winning the hearts and minds of the hesitant ones, because people in principle, they are lazy. If they see that somebody else is checking their blood test result online, they want it too. According to the OECD, 1 in 10 patients is unnecessarily harmed during healthcare. And more than 10% of hospital expenditure is spent on correcting preventable harm. But at the same time, only a minority of countries are using health data to monitor healthcare quality and performance and using it for clinical decision support. We can explain to our people that this will be to their safety and benefit. I fully endorse the principle that in healthcare, the privacy of data does not mean that the data should be secured from being used, but instead that the data should be used securely, knowingly. Estonia is ready to share our experience in digital trust services. They are social, they are technological, and they are legal. A simple but powerful example of how this combination is executed in real life is the fact that in Estonia, every citizen has a complete overview of who has access to their digital data. It's in state service, but it doesn't belong to state, it belongs to people. Snooping in the state service, by the way, is criminal offense. And it's not empty words. If somebody has snooped, let's say looked at the data of their ex-boyfriend's new girlfriend, they lose their job and there is criminal prosecution. There were very few cases until our population learned this is not a done thing. It's not much better than, absolutely not better than reading letters of, well, which are dedicated to somebody else. But it takes teaching, it takes examples. Above all, it takes courage to say we will do it this way. We know and we aspire to that digital transformation will change the healthcare in coming 5 years. It should empower citizens and personalize their treatment, and it should make health systems more sustainable because it's more effective and efficient, and people will arrive at doctor's doorstep quicker. It will create opportunities for growth from data-driven R&D. And digital solutions can already support people in managing daily their chronic health condition. They are privately offered, many people use them. We have digital assistants for blood sugar control. We have digital assistants to support effectively us in controlling our mood if we have depression. In Estonia, we have developed, for example, a solution called Cognius to assist people restore their cognitive skills and speech disorders after a stroke. It is possible only digitally to really equip everyone with instant best medical advice using artificial intelligence. We know that in North London, NHS is already testing out a medical chatbot as a non-emergency helpline. In this context, it is important, while we already have the tools, to enable people to better understand and manage their own health with easy access to information and digital tools. All the bots online now function without real medical data. They shouldn't. They would simply be safer to use because people will not stop using these online tools. Right now they do it based on hearsay, what they can remember from their medical file. Yet they already do. This is not safe. According to the 2014 Eurobarometer study, 6 out of 10 Europeans go online when looking for health information. Almost 8 out of 10 of 15 to 39 years old have done so. Less than a third of people aged 55 and over, but still. And 90% of those said that the internet helped them to improve their knowledge about health-related topics. Had they been able to safely merge what their doctor knew with the robots online, their information would definitely have been of higher quality. The more these bots and AI tools are able to use data, the more precise their response would be, again, making their use safer. And the bottom line is not either to use or not to use. People use anyway, so we simply need to make sure that it's good quality what they use. The EU General Data Protection Regulation, which will become applicable as of May 2018, this provides the legal basis for the free movement of personal data, the right to access, and the right to portability of personal data, allowing people to have control over the use of their data and providing transparency about its use. This is instrumental for public trust in e-services. We do have already first success stories from European cross-border collaboration. Next spring, some fellow Europeans can expect that their digital prescription will be valid for purchasing their drug in another EU member state, be it because of an emergency or because they are on a longer holiday or work assignment abroad. We can already build virtual medical knowledge and treatment teams across borders, and we do. European Reference Network for Rare Diseases does facilitate best possible diagnostic and treatment options in respective centers of excellence for all citizens. Europe can guarantee and must guarantee that if people want, their health data from their previous doctor will be available for use where and when they want, quickly and accurately. Last but not least, the future is brighter for everyone. If we make use of the vast amount of data generated every day in health sector to contribute to this outcome-based organization and financing of healthcare, by allowing monitoring of healthcare quality, providing more transparency, and enabling evidence-based policy and decision-making. Big data applications in research and innovation in healthcare, they will enable better prevention, diagnosis, and treatment. They will be legally possible. It can also enable the early detection of infectious outbreaks and accelerate development of medicines and medical devices. It can stimulate innovative healthcare solutions, such as telemedicine and mobile health application. Of course, they are also, from the other side, potential new economic growth engines, business opportunities, jobs, investments created by data-driven healthcare innovation. And this is also good for people, both sick and healthy people, obviously. However, we must acknowledge the new uncertainties, and we must face this with implementation of digital solutions, which recognize these uncertainties and deal with them. We could use AI for optimizing the use of limited public resources and let the machines decide the entitlement for services, for example. We could use AI first and foremost as a tool for doctors to optimize their treatment decisions. And this will already reward our healthcare budgets. Now, how can we accommodate robots and artificial intelligence into the sector which is primarily about human touch and human feelings? Yes, it is probably more efficient, and some people will accept it more willingly. But in order to make it a part of mainstream, we need wise and really long-standing effort to get ourselves used to it, as well as to learn what these new miracles will not solve for us. To conclude, I would like to answer the questions, why Europe and why now? We discussed some examples previously, but most of these digital solutions, they are not yet available as the mainstream solutions. We have barriers or the borders, so that people travel much more freely than their data does. European public finances cannot be effectively managed if we do not modernize our health systems using data and analyzing it. Yet it takes money to start organizing all these new elements. Meanwhile, we cannot cut the old-fashioned budgets or the parts of the budget which we still need in a less effective way than we think it will happen in the next 10 years. But gradually, doctors across Europe should start prescribing trustworthy and effective apps, and European citizens should be able to benefit from solutions from all European companies. This can only be achieved if digital single market comes into being and is put to work for its people. All European citizens should have user-friendly digital access to their health data and own ability to facilitate the use of this same data by other players that can offer better services by using this data. You can offer this data to serve yourself, but you can also offer this data to serve the whole community, to make our AI tools cleverer, sharper. The data will always belong to a person, to a human being. But they need to learn to donate it, if you wish, to the wider public, knowing that it is safe. We have taught our people to think about the future beyond their own existence. Donation of organs. We donate blood regularly, all we do, I believe. Donating our data is actually not a physical process, but it is as scary for some people. And I am very thankful to all people who have made this conference a success to help us and our societies to overcome these worries, these fears. I thank the organizers, the presenters, and the moderators. I thank companies by showing what is already possible, but most of all you, participants, by being active participants. And I thank you in advance for taking these messages from Tallinn elsewhere, helping us to convince us to make our Europe more healthy. You have proven that the topic of digitization of health systems in Europe is possible, but not everybody does know it yet. Since our people, our businesses, everybody already is online, our governments have to follow. There is no other option, basically. And healthcare, digital health society, this is very much a big part of how people see and feel and touch their government in practice. The Digital Health Society Declaration encourages us to act, and I believe in these 3 days you have worked it through how to act. I wish you good health, safe journey back home, and I hope you had a nice and interesting stay in Tallinn. Thank you for listening.
Thank you, Ms. Kersti Kaljulaid, the head of state of Estonia. And for concluding remarks of the conference, I invite to the stage the Deputy General of Estonian Ministry of Social Affairs, one of the main organizers of this conference, Mr. Ain Aaviksoo, please.
Thank you. I've been just raised to a Deputy General, so...
What is the
No.
Director General?
That's cool. Deputy Secretary, I've never been Deputy General, so I kind of try to accommodate myself. Well, you heard what our president told. I can only but second to her and say to all of you, thank you. It was early 2016 when we started to work in our team, think about the presidency. Well, we thought, okay, probably there will be conference because the original idea was to have the presidency in the first half of 2018, and then usually there is an e-health conference in Europe. And then council conclusions already at that time also seemed like an idea that we want to put on table so that ministers can say strong message what they want of it. Well, then it was June 23rd and changed the world. At least for us, we had to do it 6 months faster. Well, we thought, what the heck, we can do it. And then we came up with the concept that instead of just having politicians talking to themselves, then having conference where all the good friends, new and old, specialists, experts come together, we want really a change. We really would like to have something that the presidency is a platform for ideas, but more importantly, willpower and commitment to act. And then, when in Malta in May, we carefully suggested that perhaps something like a digital health society and bringing in also stakeholders could say something what they want out of that, and then we can discuss that at the conference, and then in the end the ministers would seal it with their political commitment. Good colleague of mine from the Netherlands, tall man, Erik Gerritsen stood up and said, well, why only talk and write papers? I want something to be done. And today, in addition, we do the political will that will be presented. We are still working on that. Actually, there is quite good negotiations have been taking place, and seems like it's a promising result. But over this conference, I heard several calls that actually we should make it even stronger. So we will make it as strong as the European health ministers. Actually, with your help, when you go back home, you heard the minister go back home, the president told that go back and tell your ministers that actually we can deliver much more than we're doing right now. And also, I have to thank that while preparing the conference, but also while working with this European Union presidency as a platform, I learned a lot how to collaborate, and I can tell you, it is possible to collaborate with the European Commission. Indeed. And this support from other member states, support from colleagues, but also different professionals, understanding what can be done together with different member states, together with the Commission. We have had this conference. I am sorry I have not been able to participate and listen to all those 80+ presenters that have been here. But I have been told by many people that they have done a great job. So thank you all for that. And I can tell you that this doesn't stop here. We have the Digital Health Society Declaration. We have the content up for signing. And I know that we can already count in double digits the organizations who have supported and signed it. A great number of organizations have said that they will now go back and get their formal approval in their respective organizations to support it. And we also have 4 task forces who have committed to deliver clear action plan, and we do have member states, in addition to Estonia, who have said, yes, we will start taking those on board and start acting. And we have eHealth Network working with all member states together with the European Commission, again, who has said, we will take this up and we will start making on our next decisions based on that. So we keep working on the, or towards the coalition of the willing, or as it was put here, let's call it coalition of the doing. And hopefully we have signatures of the first real action on it also internationally in Europe. So, this would not have been possible if there weren't a lot of enthusiastic and hard-working people. And I will ask you to applause, and for the sake of time, I will list some of the names, the most important ones, but so that you know that, and now is the time to start applauding. Piret, Monika, Nele, Kelly, Rainer, Ellen, Marje, Saskia, and all the government office people led by Piret Lilleväli and Rauno. Thank you. This is my bow to you. And then we have good partners that have helped us to prepare and to deliver here. So I will invite on the stage first, this is my iPad, you know why I need it, right? Mr. Vincent Monchamas from HIMSS.
In my capacity of HIMSS Europe Governing Council member for nearly 3 years, and on behalf of HIMSS Europe, I would like you to take this opportunity to say thank you to each and every one of you for joining us here in Tallinn. HIMSS Europe conferences have been collocated with European presidencies on several occasions, and we hope that this event has once again proven to be fruitful and meaningful for more than 700 people who attended. As we close, we want to involve everyone sitting here today to 2 key initiatives that HIMSS Europe will be championing over the next 6 months. Firstly, we want the Future 50, supported by IBM Watson Health. It's a new initiative by HIMSS Europe to identify and bring together the top 50 healthcare IT leaders in Europe in a community that will be further the field's transformations. We want you to nominate yourself or those who you feel has the potential of digital health to improve healthcare for all of us, so that we can give them a platform to make that a reality. Secondly, the Kay Granger Awards are now open for nomination. The awards, which are in the 2nd year, were created by Dr. Kate Granger, a British doctor who worked tirelessly to recognize outstanding and compassionate care in healthcare settings across Europe. We ask you to think about those who are making a difference in this area and let us know. Both of these initiatives have been found on the HIMSS Europe website, and the individuals who are part of this 2K initiative will be announced at the HIMSS Europe and Health 2.0 conference next May. On that note, we are also excited to be announcing this conference to you today. HIMSS Europe and Health 2.0 are thrilled to be collocating their events together next year, on 27-29 May in Sitges, just south from Barcelona. Bringing these two organizations together is a truly unique opportunity to unite the entire healthcare ecosystem. HIMSS Europe reaches with health authorities, hospital C-suite on one hand, and Health 2.0 entrepreneurs and startups on the other will be gathered under one roof. This conference will be one new flagship event and will be the key gathering for the acceleration of digital health in Europe. We would very much like for you to be a part of it. We are also honored to announce that the Dutch Ministry of Health, Welfare and Sports will be our key partner for this event, bringing immense added value to the program and bringing innovative solutions and experiences for us all to learn from. Again, thank you all for coming to Tallinn, and on behalf of HIMSS Europe, we expect to see you in Sitges in May next year for our flagship conference. Thank you.
And last but not least, Mr. Brian O'Connor from ECH Alliance, the brain and a good friend behind the Digital Health Society, together with Julian Venn, who left. Please, I'd really like to thank you, but I know that this won't end here for you as well.
Okay, thank you. So I'd like to start by saying some of you who were at the opening ceremony will remember we had the deal, which is the losers and the winners, okay? So I've noticed lots of people taking photographs this year of this chair, which are the winners, for anyone who's confused, and no one at the loser's chair. And my take from this conference is this, that this has been unusually practical, productive, and from that comes a real determination. And the answer to the President's question, is anything going to change after this conference? First of all, I'm going to have a sleep, which will mean I'll feel much better afterwards, because we haven't slept for about 3 days. But more importantly, what comes across to me, and I hope to you, is that the 4 task forces who have met here the last couple of days, who have had their sessions, have had many, many, many others now asking, can they join those task forces? We made the statement at the beginning of the week, please do not sign the declaration unless you mean to do something. And I know 1 or 2 of you said to me, that sounds quite rude, you know. And I said, no, I think it's real, it's practical, and it's the way we work. So I repeat the same point. We want you to sign, but only if you are committed. We want you to do real things which will change the lives of real people. I think Estonia have shown us the way. And I listened carefully to what the President said about trust. That level of trust, in my view, does not exist, I'm talking about digital now, necessarily across the whole of Europe yet. One of the problems we have in Europe is we try to get a consensus all the time. As an Irishman who also is British, so I've got foot in both camps for Brexit, what I would say is, I've watched people struggle to get everyone to agree to anything. I tend to favor benevolent dictatorships, in which I would be the chief of staff of the armed forces. Never be the dictator, because you can be removed. But what I'm trying to say to you is this, it's really important that we don't wait for everyone to catch up. It just will not happen. We've been at many conferences where the same people talk to the same people about the same problems. And there's only one conclusion usually. Why do we meet again to talk to the same people about the same problems? That's past, that's old hat. I am really encouraged by the elements that have come together. The eHealth Network, many countries we've met this week, the European Commission, the digital single market, the review of the market. All of these actions are in themselves really good. Combine them in some way, connect the dots. We can actually make a difference. And remember what we said at the beginning. This is about citizens. All the companies, and I'm a commercial guy by nature, we will all benefit, but only if we think and understand why we're here. We're here to look after ourselves, being selfish, our families, our friends. So my last word to you would be this. I think the Estonian team, the people who have had the courage to be bold, to be active, and above all, to produce a legacy from a presidency, which will continue far beyond the official end of the presidency in December. And that's the good news. People want this to continue into future presidencies, but more importantly, into future actions. And I just think, if I may ask you to have another round of applause, because I think the level of people in Estonia who have actually had the courage above all, the conviction, and then the ability to deliver is unusual. So I would like you maybe to join me in thanking Ian and his team again, because I think they've done a fantastic job. So to finish on a very optimistic note, you will not all fit physically on the chair. And unfortunately, we didn't have time to create a digital chair for all of you. But the digital chair is actually the declaration. It is the commitment to the task forces, and it's the commitment to not just meet again to talk about the same things, but to check whether we've made any progress in a few months' time. So thank you very much for all your support for us, the EC Italians, and for your enthusiasm, which keeps us all somewhat young. Thank you very much for listening.
So, this is it. This conference is over. We will keep working, but in between there is now free food waiting for you. So, welcome back always here to Tallinn.
Thank you.
So thank you everybody.
Thank you.
Lunch and networking, and as Ain said, come back to Tallinn and visit us. Thank you.
Good job.